And I hand over the mic to Dr. Anil Dhingra to introduce the speaker of the day.
Thank you, Dr. Tuli. So we start with the first lecture of the day by Dr. Pandit. Madam is a 1993 graduate from SCB Medical College, Cuttack. She completed her MDS in periodontics from Government Dental College, Ahmedabad. She has received the Best Graduate Award by ICDRO in the year 1993. She is the recipient of Colgate-Palmolive Award and ISPPD in 1993 and Guidant Award in 2011. She is presently working as Professor and Head, Department of Periodontology, DAV Dental College and Hospital, Yamunanagar. She has more.
Check. 1, 2.
Good morning, sir.
Hello.
Now I request Dr. Pandit to please come on the dais for her first lecture of the day.
I have this mic.
That is not working.
Hello. Am I audible? A very good morning to all of you. It's heartening to see that people are sitting at 9 o'clock in the morning. I'm very thankful to Dentocon 3 for inviting me and be a part of this scientific extravaganza. I'm very thankful to Dr. Himanshu, who always considers me and gives me an opportunity to present my thoughts on whatever I have done. And I'm very happy to see many people here who are my friends as such, Dr. Amrinder and Avantika and Tarun, Dr. everybody over here. Thank you so much. So I have chosen a topic which is common to, I think, all the dentists. You see the patients of hypersensitivity throughout your clinical practice, and it's something which we think is very easy to manage, but sometimes it becomes a problem because many people do not get relief with the conventional methods and what we have in our paraphernalia to present them. So with that thought, I thought I'll go a bit deeper into this. I will give you an overview of that, and I'll give you an idea about the different clinical situations, how to manage hypersensitivity in different fields. So what hypersensitivity, it's a problem, it's a concerning problem of that causes pain and discomfort, which is very irritating to the patient. And the problem is that over a period of time with the literature, we have seen that there are significant gaps in the literature related with that it's underdiagnosed, it's differential diagnosis is not done properly, and treatment strategies sometimes don't work, and we do not have a plan to go further in those patients where normal conventional method do not give any relief to these patients. So there are two aspects of this. There's a patient perspective and a clinician perspective. For patient, it's a very common chief complaint, and they try to ignore it over a period of time. They think it will get over, but we need to, from a clinician's perspective, we need to intervene at an earliest so that it doesn't go to the area where we will have to have more complex treatments for these patients. So if we look at the guidelines, what we formulate for managing any problem in the medicine or in dentistry, the highest goes that there are a group of clinicians who go through the literature, they find the best evidence, and then they give guidelines for management of a particular problem. So those clinical guidelines, the management of a clinical problem, are at the highest level of the pyramid, where we go from case reports to RCTs to meta-analysis. Formulation of guidelines is from the meta-analysis, and those form a guide for the normal dentists to follow, and that gives the best type of outcome in relation to the patient management. So these clinical practice guidelines. With this idea, Indian Society of Periodontology, we took out a survey for 3,000 dentists across the country, and we tried to fill in those gaps, what I was telling you, these gaps related with how we diagnose the condition, how we try to manage that condition. There were clinical gaps related with that, and it was done in December 2020. So there was this expert consensus who were divided into different groups, and these groups took different meta-analysis and systematic reviews, and those were reviewed, and then they formulated some guidelines on that. And they tried to devise methods which are practical for the normal dentist to follow, and who gives them clear guidelines how to manage a different type of a condition. So this was the group who was working, and we had almost 30 people working on that, who took different parts of that, and they specially consulted those articles only which related with that particular area of dentinal hypersensitivity. So this group formulated some guidelines, and this is the publication that we had. We had these guidelines in the periodontal care in Journal of Indian Society of Periodontology, and there were, what we got from this survey is that we found out that if we are doing a survey, there are almost 4 to 74% of the people have hypersensitivity, and in this Indian scenario, we try to make a common middle percentage, that is 20.6% of the people do have hypersensitivity of their teeth. And out of these 26%, almost 67% they ignore the signs. And this is the danger point. They ignore the sensitivity signs, and what they do, they try to avoid cold drinks. They try to eat a different way. For example, somebody uses a straw. 73% compromise on that. They allow the cold drink to become hotter and then have it, and some just tolerate it. There are different problems with the diagnosis also. If we see the diagnosis, how we diagnose hypersensitivity. If a patient comes with a chief complaint of hypersensitivity, how we diagnose it? Do we look at different areas? Do we have the differential diagnosis to delineate and rule out the problems which are not dental hypersensitivity and accordingly manage them? So there are two things. Self-reported questionnaires, they give us bigger figure of hypersensitivity, because these self-reported questionnaires will also think that the hypersensitivity caused by caries, by cracked tooth syndrome, or by any other method is also dental hypersensitivity. This should not come in the dental hypersensitivity. Caries itself causes sensitivity, but that does not come under that. So they give a higher prevalence, which is not only hypersensitivity. And clinical examination also, the problems with clinical examination is, if we are evaluating the hypersensitivity, we may evaluate it only on the buccal and lingual part, the interdental part we may miss. So there are problems with both questionnaires as well as the clinical examination. So what do we do? There were two definitions given for the dental hypersensitivity. The first definition was that it's a pain arising from the exposed dentine, and later on, it was again from the Canadian Advisory Board, it was again elaborated in a bigger degree where they said that it's a sharp pain which is from the exposed dentine and interrelated with the stimuli, typically thermal, evaporative, and tactile and osmotic. And there was an elimination of other pathology which may cause this sensitivity. So this definition was a more elaborate definition. Now this is a small, I hope this works. Sound इसकी नहीं आ रही है. So gingival recession cause hypersensitivity. There is exposed dentine with the wider dentinal tubules, exposed dentinal tubules. And deep down, there is osmotic fluid movements, which irritates the nerves at the end of the tubule, and this fluid movement irritates the nerves, and that causes hypersensitivity. So this is how the hypersensitivity develops. So now there is another term, dentinal hypersensitivity and dentinal sensitivity. Do we call it sensitivity, hypersensitivity, or sensitivity? There was a school of thought who said that it should be called sensitivity because once the dentine is exposed, it's sensitive. But this is not the case. Dentinal hypersensitivity means not only the exposure, it also means that more tubules are open and more tubules are wider in number. So it should be called dentinal hypersensitivity, and dentinal sensitivity is a misnomer which should not be used. So it is more wider and more tubules at a dentinal level. There is another term which we should know, that is root sensitivity. Root sensitivity is a different term which specially relates to the exposure of the root dentine, and because of the periodontal pockets, because of the recession, and because of the exposure to an environment, for example, saliva, which is not very normal for the cementum. So this is another term, root sensitivity and dentinal hypersensitivity. These are the two terms that are now accepted in the literature. So these are the three theories which almost everybody of you must be knowing, that hydrodynamic theory is the one which is accepted because we do not see any nerves at the dentino-enamel junction, and there is also no evidence or support for having it as the odontoplastic process is getting sensitivity or having sensitivity at the dentino-enamel junction. So these are some of the etiological factors. So the most important thing from a periodontal point of view is that when we do scaling and root planing, the thickness of cementum at the cervical end is just 1 hair thick. So if we are doing vigorous root planing, then we may expose the dentine, and we may also make it wider and more number of dentinal tubules exposed to the environment. The tooth bleaching can be there, tooth wear can be there, and oral hygiene and recession can be there, and developmental regions. So these are only the 5 conditions where we diagnose it at dentinal hypersensitivity. The other conditions, we will have a differential diagnosis and treat them accordingly. So these are the 4 terms which we usually use: attrition, erosion, abrasion, and apraxion. Now there are one things which you need to learn is that there is pathological wear and there is physiological wear. If there is a physiological wear, what will happen, that secondary dentine will form and the patient will not feel hypersensitive. But if it's a pathological wear, there will be sudden cracking or chipping of the enamel, and this will cause sudden pain in the patient. So developmental lesions can be there. For example, enamel formation is somehow not correct, hypoplasia is there, or hypomineralization is there. Now tooth bleaching is another reason for the dentinal hypersensitivity, but this does not come under as such because its etiology is different and we do not diagnose it as dental hypersensitivity. We need to understand that tooth bleaching has to be done in a proper way, and then it will not cause hypersensitivity. So what are the factors related with the oral hygiene? We usually see sensitivity in the people who do vigorous brushing, who do incorrect method of brushing, who have recession, and who are doing excessive times brushing. That pressure also, and placing more pressure in the tooth areas. Now, how do we diagnose? There are different methods of diagnosis. We have mechanical, we have chemical, electrical, evaporative, and thermal methods. In the mechanical methods, we usually, what we do in the clinics, that we run a probe along the area where the hypersensitivity is there. But that pressure, how much pressure one clinician is placing and how much pressure another clinician is placing is different. And in that way, we may have pressure sensitive probes where there is calibration of the pressure what we are doing, and up to 70 PSI, if we get the hypersensitivity, that means that is not very hypersensitive. At a lower level, if we get hypersensitivity, then there are chemical methods, there are electrical stimulations, pulp testers, evaporative methods where we place some material on that, and thermal stimuli, for example, hot and cold, and sometimes ice sticks. Now, how do we diagnose and how do we work up? Now, we have screened the patients for the pain of hypersensitivity. Yes, we do examination. We see chief complaints mainly from the purpose of having a differential diagnosis, so that we do not put the cases which can be managed by something else into the dentinal hypersensitivity cases. We ask for symptoms and history of present illness. Then we evaluate, and then we manage the hypersensitivity. Now, these are some of the things that need to be seen, and they need to be ruled out before we give desensitizing agents for the management. So first is the dental caries. It has a different type of sensitivity which is experienced. Cracked tooth syndrome, on biting, we will feel more pain. Traumatized teeth, we can see on the examination that there are some cracked areas, and that causes hypersensitivity, because this management of these cases is different from how we manage the normal hypersensitivity. Pulpitis, irreversible and reversible, you need to delineate. And lateral abscesses of the periodontium also, these also will present clinically in a different way. Bleaching or sensitivity also needs to be eliminated for that. Post-operative sensitivity, for example, the dentists over here, they will say that after filling, you tell the patients that you have sensitivity for some time. That is normal. It will go over a period of time. Or if some fillings are there which leak over a period of time, that also will cause sensitivity. But those cases need to be managed in a restorative way rather than treating them with desensitizing agents. Now, there are 3 phases of treatment which that consensus gave, that guidelines gave, is that first is the patient education and behavior modification. Then we shift to non-invasive methods, and the last is the restorative or the invasive methods that we use. So if there is a minimal loss of the tooth structure, those cases we usually manage with the desensitizing agents. And these agents either work by occlusion or by nerve desensitization. So these are the 2 ways where the desensitizing agents work. So what are the ideal properties? They should be fast acting, they should have a long lasting effect, they must not cause harm to the pulpal tissue, and they should be convenient to use and pain free. Now, there are 2 aspects. One is you want to get rid of the dental sensitivity immediately, and then you need to have a long lasting effect. Occlusive dentinal desensitizing agents, they usually give a fast relief, but they are not long acting because they wear off over a period of time. But if you need to have a long term, then you need to use the fluorides, which work for a longer time and which will have a lasting effect. So there is a combination of 2 agents which give immediate relief as well as a long term relief. So these mechanisms, the mode of action, you can have a mode of administration is at home, you can give the desensitizing agents, or by the professional, which is more complex and which is more costly for the patient. And mechanism of actions, those who disturb the neural responses and those who block the responses, as you can see from the figure. Now, we have 3 agents that we use at home, that is desensitizing toothpastes, mouthwashes, and herbal agents. As Indians, we do have belief in the herbal agents that also work. And these are the different agents that are used for the nerve desensitization, potassium nitrate and other tubule disocclusion. The recommendation for the patient, what you need to tell the patient is that use a soft brush. And if your cause of the sensitivity is because of the acidic food, then brush before meals, because after taking acidic meals, your dentine becomes softer and it will wear off with brushing. So brush the teeth before the meal and then only have your meal. So these are some recommendations, and it takes some time for this to evolve. You should tell the patients that you have to make some changes in your lifestyle and avoid citrus foods, and you should avoid brushing in a horizontal direction and give them the correct method of brushing. So these are the related. Now, if you want to have from a periodontal point of view, how we can prevent sensitivity, because the patient comes to the periodontal clinic to have his treatment for periodontitis, but what he takes is the hypersensitivity. For these patients, there is a guidelines for the clinicians that over-instrumentation should not be done. You should not do too much polishing of dentine, and the patient should be careful during the home bleaching, or you should also not have any gum injury during your bleaching at your office. So these are the recommendations for the dentist. Now, there are physical occlusion of the dentinal tubules and the chemical. Chemical ones usually are the fluorides, oxalates, and gluteral-based agents, and the physical agents are the resins and dentine bonding agents. Now, I'll give an overview of these agents, what are available in the market. First, there was this copal varnish, but it did have a desensitizing effect, but it was not long-lasting. So newer agents came, which had fluoride, as I was telling you, that fluorides make fluorapatite, and that has a lasting effect and a long duration of effect. And 5% sodium fluoride varnishes give better results over a period of time. Oxalates, these are one of the best materials which can use because they are resistant to acid attack. If your dentinal tubule occlusion occurs by oxalates, it's a long-lasting and a good effect, and these patients will have a very good response to the treatment. Next is the gluteral-based agents. These make plugs of resin into the dentinal tubules, and it has been shown to penetrate tubules up to 200 μm, and they prevent the osmotic exchange of fluid and the nerve sensitization in those areas. The other physical occlusion is by the composite resins. You can have normal composites, and you can have the light cured composites, which can be used over a period of time. And fluorides can also be incorporated. The resins will give you an immediate effect, and the fluorides incorporated into the resins will actually have a long-lasting effect because that will form the fluorapatite. Dentine bonding agents, usually they have interdiffusion hybrid layer, and they form a layer on the dentine, and that blocks the steps. Now, these are also, I think most of you know that there are different steps in that. Earlier we had 3-bottle system, then we had 2-bottle system, now we have 1-bottle system. Only etching, bonding, and curing takes place in 1 bottle. So these different steps are there. These agents, which are like ethyl methacrylate, they are most widely used in the dentine bonding systems, and a combination is also used in some cases because these two agents, they work at different systems. One is hydro need etching, you do not need to remove more tooth structure, which is the main cause of the hypersensitivity, and these work very well in the situation where you have to bond the dentine in the root area as well as in the crown areas. So these are different agents. So material selection, usually you should have the choose if you are at the office treatment, then the composites, glass ionomer cements, and resin modified glass ionomer, these are the agents that can be used over a period of time. And then you can have the one new paraphernalia that has been added for the management of hypersensitivity at the lasers. Lasers, there are 2 types of lasers which usually act by either melting the dentine and blocking it, or by making protein coagulation. If you have a protein coagulation, that will occlude, and if you have the melting of dentine, that will seal the dentinal tubules and cause desensitization. So NDYAG acts by the coagulation, and it also helps by the melting of the dentinal walls. The next, that is surgical part. Now we are going to the third part, that is the surgical part. We can manage, if you have a recession, you need to cover it. You need to prevent the further recession by motivating the patient to brush in a better way, to brush with a soft brush and with a better technique. So soft tissue coverage is used in those cases where the dentine is exposed in the root area, that is the root sensitivity is there, and that will either be used with the bonding agent or without the bonding agent. We'll be discussing that shortly. And if nothing works, then you need to go for the endodontic treatment. Now, ISP made guidelines related with how you categorize these patients. If the patients come to you, you can have 4 situations over there. Either there is only soft tissue loss, only hard tissue loss, no soft tissue, no hard tissue loss, and both loss. So these 4 categories of patients actually should be managed differently. Now you have a patient who has no soft tissue loss, no hard tissue loss. In those patients, you usually give mouthwashes and desensitizing agents. That should be enough, because this is usually because in the cervical area, it's a very thin gap between the cementum and the enamel. So that is the reason for that. You need to delineate these patients. Next is hard tissue loss is there, but no soft tissue loss is there. You have to see how much hard tissue loss is there and manage it by restoration or just by the bonding agent. Third situation is where there is no hard tissue loss and soft tissue loss. As we have already discussed, we need to go for the recession coverage in these patients. That is periodontal management, and some physical or chemical occlusive agents can be used in these cases. And fourth situation is where there is both hard tissue as well as the soft tissue loss. In these, you may go for the restoration if the hard tissue loss is more, and you also have to go for the recession coverage. So this is the bad. And the most important thing that we devised by this consensus statement is that you don't have to get disheartened if the patient comes back to you and says that my hypersensitivity is not going in any way. Now there are 3 C's which are devised for that. That is continue, there is change, and there is C's. Now the patient comes to you and he says there is a marginal difference in the sensitivity that I came with, then you need to continue with that treatment. If the patient says there is no relief from the hypersensitivity, you need to change the agent, and you need to look closely that you have misdiagnosed, or over a period of time, the patient may have developed some caries, he may have developed cracked tooth syndrome or other problems. Then you need to change the strategy of treatment or change the agent. And third is, if the patient says, now I am relieved from the hypersensitivity, you need to cease the patient. So for the recall appointments, there are 3 C's that have to be followed over a period of time. So I want to conclude that it's one of the most frequently encountered clinical conditions in general practice, and it's prudent of us to be aware of various etiological agents and first manage the etiological conditions, then only go for the treatment part. And active management should not involve only a single agent, it should involve multiple agents. And usually, according to the diagnosis and according to those 4 categories, you should try to devise the patient and make the patient feel comfortable. Thank you. Thank you for such a patient listening.
Hello. Thank you, Dr. Nymphia ma'am, for this enlightening lecture. I would request the chairpersons of the session, Dr. Anil Dhingra sir and Dr. Gaurav Pratap Singh sir, to please felicitate ma'am. Please give a huge round of applause. I would like to also call upon organizing committee member Dr. Amit Agarwal to felicitate the chairpersons. मैडम को बोलो Nymphia ma'am, please join for the felicitation. Please give a huge round of applause. Thank you very much. Now we will continue with the next session. For the inauguration, I would like to invite Dr. Jyotsna Seth on stage. As we are waiting for the eminent guests to arrive and the inauguration to start, let us have a break in the academic schedule. Let us play a little bit of game that is known as the Mind Scrabble. I would request that we will ask one question, one answer you will give. Please raise your hands for the answer. And our volunteers will come to you with the mic. And please answer and we will take down your answers. And total in the end of the session, we will give the gifts. Everyone ready? Okay. So the first question of this Mind Scrabble is, saucering out small pits to improve self-cleansing. This property is called, please raise your hands. Okay, one girl has raised her hand. Please give me the answer. I cannot hear.
Enameloplasty.
Yes, right answer. Everybody, please give her an applause.
Good morning, my name is Gauri Chandok.
Yes, she is Gauri Chandok. Please give her a round of applause. Thank you, Gauri. The next question. In detection of dental caries using Diagnodent, the instrument readings higher than dash, they suggest the presence of dental caries. Any answers? What should the reading be? At what reading, if they are higher than this reading, will the answer be that presence of dental caries is confirmed? Pass on. Come on. PGs, endodontics. Oh, that's sad. Never mind. On to the next question. The least soluble cement in the oral cavity. The least soluble cement in the oral cavity.
Raisin cement.
Yes. Thank you. That is the right answer. Your name?
Ayushi Rawat.
Okay. Please give a round of applause for Ayushi. The next question, very easy, you must know. Specific plaque hypothesis was put forward by Perio. Oh, okay, batao. Our own student. Lush. Spelling?
LOESCHE.
Very good. Huge round of applause. Great. Name.
I'm Dr. Priyank Rathi.
Yes. Applause. Good job. Just one more question. Which periodontal fibers are also known as the interdental ligament? Okay, उसी एरिया में सारे आंसर्स हैं लगता है. चलिए. नहीं सर. Which periodontal fibers are also known as interdental ligament? Answer? Google कर रहे हो तुम लोग? Please no Google.
Transeptal fibers.
Yes, that is the right answer.
Dr. Shivani.
Your name?
Dr. Shivani Upadhyay.
Dr. Shivani Upadhyay. Okay.
Same college.
So next. Okay. One more. For the prosto people. The first porcelain tooth material was introduced by. The first porcelain tooth material was introduced by. Come on. So many students, UG, PG. Let's take a guess. गलती हो जाएगा. No one? नहीं sir. No negative marking. Okay, on to the next question. Average enamel lost by acid etching is how many microns? कितना? Minimum? Acid etching से थोड़ा बहुत enamel loss होता है. Let's take a guess. कोई guess तो दे दो. Endo, conservative. Okay, next question. This is a very easy one. HIV virus is what kind of virus? This is very easy. Everyone should know. Okay, lot of hands up. Udhar piche.
It is a type of retrovirus.
Yes, very right. Applause. What's your
Myself,
name?
Arjav Rana. Arjav Rana.
Jabrana. Okay. Thank you very much. Now, which type of Oral lichen planus is often asymptomatic. Clinically, oral lichen planus has various types which are visible in the mouth. Which one of them is asymptomatic, which does not cause any pain? It is very common. No answers? One answer. Okay. Please give me the answer. Yes, reticular is the answer. Please give your name. Doctor? Dr. Vaishali. Thank you very much for all the persons who have attempted and won. We will definitely give you your prizes. And be ready for the next session. Thank you.
I request all the dignitaries to be on dais. I would request Dr. Hemchandra sir, Dr. Rajiv Chuk sir, Dr. R.K. Gupta sir. We have Pujya Swami of Deshanand Giriji here with the chief guests. Can we have a round of applause? I would request Dr. S.S. Jha sir to please accompany with us on the dais.
तालियां रुकनी नहीं चाहिए। वक्रतुंड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्व कार्येषु सर्वदा। श्री गणेश जी के आशीर्वाद के साथ मैं डॉक्टर निकिता पंडित, फाउंडर IESRF आप सभी का देवभूमि ऋषिकेश में स्वागत करती हूँ।
A very good morning to all of you. I, Dr. Jyotsna Seth, convener of Dentocon 3, welcomes you all. Dentocon 3, we welcome you all to Devbhoomi Rishikesh and Seema Dental College and Hospital Rishikesh. We welcome all our dignitaries on the dais, Pujya Swami of Deshanand Giriji, Chief Guest, Dr. Hemchandra Sir, Vice Chancellor, HNB, Garhwal University, Uttarakhand University, Dr. Rajiv Chuk Sir, Guest of Honor, Dr. R.K. Gupta Sir, and Mr. Devendra Gupta Sir, who is the founder, Ladli Foundation. We welcome all these dignitaries and stalwarts of our dentistry. Various keynote speakers we have and various guest faculties. We have a pre-conference course yesterday and it was a great big show. To begin with, light is a symbol of brightness and prosperity as sunlight expels the darkness of night. Similarly, blessings bring in our life prosperity and happiness. To make this day a blessed one, invoke Goddess Saraswati by kindling the lamp of knowledge and wisdom. For seeking the choicest blessing for the same, I invite all the dignitaries for lamp lighting and Saraswati Vandana. It's an honor to introduce our Dr. Himanshu sir, who is a Director Principal and Professor and Head, and he's also Convener-in-Chief of Dentocon 3. He has done his Bachelor in Dental Surgery and Master Degree in Prosthodontics from King George Medical University. And he is an Master in Hospital Administration and NABH Assessor, and he's also done Master in Business Administration. He's a member Dental Council of India, 13 and 19, and was President of Indian Prosthodontic Society, and currently working as a Director, Principal, Professor and Head, Department of Prosthodontics, Seema Dental College. He has bagged a lot of fellowships like International College of Dentists, USA, Fellow of Pere Fortune Academy, USA, and Fellow of International College of Continuing Dental Education, Asia Pacific. He has done various courses from Germany as well as from USA. Dr. Himanshu sir has more than 32 leadership roles in the professional bodies, and he is attached with the various organizations like National Medico Organization, Indian Prosthodontic Society, and he is member to the various journals like a Duke's Dental Healthcare. He has more than 306 presentations, invited lectures, workshops, and invited talks to his credit. Dr. Himanshu Iron sir has more than 212 paper and 9 books publications to his credit and completed 22 research projects. He has been PhD, MDS and BDS University examiner, and he has always had the motto service above self, and he has more than conducted 850 dental camps, which is a really commendable job. Under his leadership, we have done a lot of dental camps. He has bagged various awards and honors to his credit, like various prosthodontics of the year, most proactive academician of the year, the Brilliance Academic Career, ICT Dr. Arun Sethi Award, and he has been also awarded by Honorable Vice President of India for Arogya Dental Checkup at 11th TCIW 5th International Conference. He has been also awarded by the Hem Ratna Award by Baby Rani Maurya, Honorable Governor of our Uttarakhand. I would say that at the end, the passion, perseverance, persistence make an unbeatable combination for success, and that is what he is. With these words, I would call upon Dr. Himanshu Iron sir for the welcome address.
Thank you, Dr. Josna. Shubh Prabhat, good morning. Most respected Swami Abdeshanand Giriji, Acharya Mahamadleshwar and Juna Priteshwar, chief guest of the today's inaugural ceremony, Professor Hemchandra, Honorable Vice Chancellor, Hemvati Nandan Vahuguna, Uttarakhand Medical University, Dr. Rajiv Chugh, National President of Indian Dental Association and member Dental Council of India, founder of this college, Dr. R.K. Gupta sir, President IESRF, Dr. S.H. Jha sir, our worthy chairman, Dr. Amit Gupta, learned faculty in the audience. I can't take all names, but I am very happy to see that so many dignitaries from the world of dentistry has arrived here, and I acknowledge the presence of Mr. Devendra Gupta, who is the founder of Laldi Foundation and who has been instrumental to bring the blessing of Swamiji. I thank from my heart. And today is the great morning, happy morning, blessed morning for Seema Dental College and Hospital and Dentocon 3, because प्यासा कुएं के पास जाता है, लेकिन आज कुआं प्यासे के पास आया है। हम स्वामी अवधेशानंद जी को अपने मध्य पाकर अभिभूत हैं और आशीर्वाद से उनके हम अनुग्रहित हैं कि उन्होंने हमारे बीच आकर हमें जो आशीर्वाद देने का कदम उठाया या हमारी प्रार्थना को स्वीकार किया। ये हमारे लिए एक बहुत सौभाग्य का विषय है कि कुआं खुद चलकर प्यासे के पास आया है। जोरदार ताली से स्वामी जी का स्वागत और अभिनंदन। Today's guest of honor, Professor Hemchandra sir, who is himself a personality in the field of medical education. Yesterday only I was in the academic council meeting of HNB Garhwal, HNB Uttarakhand Medical Education University, and I saw her caliber, his caliber, how simply he was handling the situation with a smiling face, and typical answers was given within few minutes, and his decision to take the on the spot decision is marvelous, and we are happy to be the part of Hemvati Nandan Vahuguna, Uttarakhand Medical University. And I would like to tell you, sir, this is your simplicity that our university is coming up like a star of in the field of medical education. And when sir joined, only 34 institutions was affiliated to this university, and today we have 96 institutions to this university. And our Seema Dental College and Hospital is the first dental college to be affiliated with this great university. Thank you, sir. We welcome you. Another personality on the dais, our guest of honor, my college senior, Dr. Rajiv Chugh, who is the member Dental Council of India and currently sitting president, national president of Indian Dental Association. He is a very busy person, and I am very highly thankful to you, sir, to accept my invitation to grace this occasion. I would like to share with you, in his presidentship, just in the beginning, he has done an innovative idea by organizing a OHIC. This is based on the innovation, and you know, research and innovation is the need of the day. And somehow in dentistry we are lacking in this. So Dr. Rajiv Chugh and his team from Indian Dental Association has taken this initiative, and they have organized a wonderful conference at Manik Shah Auditorium at Delhi, Kent. And all researchers, sponsor and research agencies was there, and that was the unique platform to interact for the new researchers from the dental field. And I would like to share with you with proud that our project from Seema Dental College was selected as the best clinical model throughout the country. Thank you, Dr. Rajiv Sukh, sir. Next dignitary on the dais is here. Because of his vision only we are sitting here today. He is no one but our own founder, sir, Dr. R.K. Gupta, sir. He could see this vision in 2003 ki there should be one dental college in Uttarakhand, and today we are celebrating the 20 years of excellence. Hats off to you, sir. Welcome you, sir. We have another very senior personality from the medical field who is presiding at IESRF, Innovative Educational Research Scientific Foundation. Dr. S.H. Jha, sir, is a very senior orthopedic surgeon and has come all along the way from Patna with madam. We welcome you both, sir, to this conference to bless us. And you know, माँ गंगा का सफ़र गंगोत्री से गंगा सागर तक जब चलता है तो माँ गंगा पहली बार पर्वतीय क्षेत्र को छोड़कर मैदानी क्षेत्र में ऋषिकेश में ही प्रवेश करती हैं। और हमारा जो ऋषिकेश है वो भगवान शिवा की नगरी कहलाता है। जब समुद्र मंथन के टाइम पर देवताओं और दानवों ने समुद्र मंथन किया तो उसमें विष उत्पन्न हुआ। उस विष को हमारे भोलेनाथ ने ग्रहण किया और वो नीलकंठ महादेव हमारे ही ऋषिकेश में उपस्थित हैं। हमारे ऋषिकेश में बहुत सारे भगवान शिव के स्थापित मंदिर हैं, जैसे वीरभद्र महादेव जिनके प्रांगण में हम बैठे हैं। और आई विल थैंकफुल टू ऑल national and international speakers who have received my invitation and accepted to conduct this conference. I would like to tell you, we have conducted yesterday 7 houseful free conference courses, and we have selected the different streams of the dentistry to train our students, and I hope our student has been benefited to the maximum. To name few, entry and posterior aesthetics restorative by Dr. Rumpa Beg, rotary endodontics by Dr. Prashant Basin, how to manage medical emergencies by Dr. Gagan Khare, art of suturing by Dr. Madhubari, and so on. And all have them as very fruitful, and as per I am getting the reports, all students has been benefited to the max. And I highly acknowledge the presence of my keynote speakers, those who have come to share their knowledge with us, with the students, with delegates. I will like to welcome with these lines, वो आए हमारे घर शिवा की रहमत, वो आए हमारे घर शिवा की रहमत, हम कभी उनको कभी अपने घर को देखते हैं. So with these words I welcome you again. And regarding little bit about Dentocon. Dentocon is the brainchild of Seema Dental College and Hospital and Team Innovative Publication from Delhi. And we have started Dentocon 1 on the hybrid, on the online mode during COVID times. and it was a very grand success conference. Then Dentocon 2 we have organized again on the online with the Jamia University Delhi, and first time we are organizing Dentocon 3 as a hybrid mode. And I would like to share with you all with proud that more than 800 offline and online registration has been done, and from every state of the India, Uttar Pradesh, Uttarakhand, Himachal Pradesh, Jammu Kashmir, Rajasthan, Madhya Pradesh, Tamil Nadu, Andhra, Karnataka, Bengal, everywhere students are here, delegates are here. Some of them are attending offline, some of them attending online. And in this, we are, as I told you, we have done already 7 pre-conference courses, and 10 keynote lectures will be giving or sharing their knowledge, and more than 210 scientific presentation will be done in coming 3 days, online and offline mode from throughout the country. So I will request you all delegates, please encatch the moment and learn the maximum. With these words, I welcome you all again. Thank you. Jai Ma Gange.
Thank you, Dr. Erin, for your encouraging words. And now I would like to request Dr. Amit Gupta sir, Dr. Himanshu Erin sir, and Mr. Ajay Garg sir. Mr. Ajay Garg sir, please come on a dais to welcome our dignitaries. I request Param Pujya Swami Avdeshanandji Giri Maharaj to welcome by Can we have a round of applause? Don't pause applauses. Thank you. Now I request Dr. Hemchandra sir to be welcomed by Thank you, sir. Now I request to Dr. Raju Kumar Chuk, sir, to come for felicitation. Thank you, sir. Now I request Dr. A.S. Jha, sir, to come. Thank you, sir. Now I request Dr. R.K. Gupta, sir. मैडम इनका नाम लिया था ये तो आई नहीं थैंक यू सर Now I request Mr. Devendra from Lardli Foundation to come on stage.
It's a proud that we have Dr. Rajiv Chuk sir, who is the National President, Indian Dental Association and member Dental Council of India. Can we have the slides, please? He is an alumnus of King George Medical College, Lucknow, and he is trained at University of Pennsylvania, USA in microsurgical endodontics. He is a founder, secretary, journal, Indian Academy of Restorative Dentistry since 2001, and editor-in-chief, product profile, and official of IDA. He is an editor-in-chief in UPDent and chairman, reception committee of IDA head office. He is also vice chairman of Pere Fortune Academy. He has been various fellowships to his credit: Master Fellow, International College of Dentists, member, National Academy of Medical Sciences, Fellow of Academy of Dentistry International, Fellow of International Medical Science Academy, and Diplomat of WCOI, and is a Fellow of Academy of Oral Academy and Fellow of Pere Fortune Academy. He is on editorial advisory board and editorial boards of various reputed international and national journals. He has a regular column on endodontics in Heel Talk Journal, and he's a managing director. He has been bagged various awards to his credit. To name few, he's the best state branch president in the country by IDA head office, first recipient worldwide of the ICD Distinguished Service Award from the ICD head office USA in December 2016. He's recognized by IDA head office publications Oral Health as a Dental Ratna in June and Dental Ratna Award by Sanodont in August. He has been a keynote speaker in various national conferences and conducted many CD programs for various national organizations of endodontics and general practitioners. And it is a proud moment to tell you that he is also doing a N.K. Agrawal oration in our Dentocon 3. He is a recipient of the various prestigious Dr. M.L. Soni oration and Professor C.P. Goyala oration by the IDA UP State Branch. For these, I would say that dream big, stay positive, work hard, and enjoy the journey. With these words, I call upon Dr. Rajiv Chuk sir to initiate the program.
Good morning, everyone. Respected Pujya Swami Avdeshanand Giriji, a great sage, an eminent Vedant scholar, and an inspiration to millions. Dr. Hem Chandra, Vice Chancellor of the HNB Uttaranchal Medical Education University, a renowned administrator, academician, and researcher. He also happens to be my class fellow. We met today after 40 years and revived some of our old memories and discussed and shared some information about our families. So what a coincidence meeting Dr. Hem Chandra today in this occasion and reviving those memories. Dr. R.K. Gupta, founder of the Seema Dental College, patron Dr. Amit Gupta, Dr. Jha, the president, and the team from Innovative Education and Scientific Research Foundation, Dr. Himanshu Aryan, the director principal of Seema Dental College, and the convener-in-chief of this Dentocon 3. It's very difficult to express a person like Dr. Himanshu Aryan, who is a visionary. I've been associated with him for the last so many decades for various organizations, and every time he surprises me with his versatility and his energy in organizing events, whether it is a scientific event, it's a social event, and every time Himanshu has been just excelling. As he mentioned, recently we had an innovation conclave in Delhi, and there also they came up with a proposal, and their project was also shortlisted for funding by one of the Shark Tank members. So, and it's no surprise that on merit, purely on merit, the Seema Dental College won an award in the Innovation Conclave. Thank you, Himanshu, for inviting me here, and keep doing well. Today, the Seema Dental College is completing 20 years, and today it's rated among one of the top dental institutions in the country. Thanks to your sincere inputs and guidance. You are a great leader. I must acknowledge that. Thank you. Members of the organizing committee, head of various institutions and faculty members, delegates, eminent speakers present here for this Dentocon, dear colleagues and students, and ladies and gentlemen. On the onset, I would like to thank Dr. Himanshu Aryan and the organizing team of the Dentocon 3 for extending such a warm welcome to me and inviting me to this power-packed event of the year. I feel honored and humbled to be awarded the very prestigious Dr. N.K. Agarwal Oration and be amongst the galaxy of clinicians and the audience present here, and be connected with some of them by the hybrid mode on this occasion. I see so many young dental professionals in the audience today. It's a great feeling to address this next generation of oral health professionals. I address you oral health professionals, not only dental surgeons, because dentistry today doesn't limit ourselves to only teeth and soft tissue. There's much more to this. So that's why I've enlarged the definition of dentistry to oral health professionals. You are going to be the power of our profession and who are going to lead this profession in the coming decades. You are going to be the torch bearers of the profession. Friends, our patients trust us to make good choices for them. We owe it to them to continuously upgrade the technologies and work with and the materials we use, the protocols that we must put in place to safely restore their oral health. It is no longer acceptable, in my opinion, to use substandard materials and outdated methods. A conference like Dentocon 3 is an opportunity for you to imbibe the knowledge of existing practices in dentistry and also gives you the insight at the way dentistry is progressing. The future of dentistry continues to be exciting, evolving, and more predictable. Dentistry today is undergoing a revolution for the better. We see so many new technological innovations, new products and processes are appearing for the first time, and they are going to be the game changers in the profession. As I mentioned, IDA recently hosted the Oral Health Innovation Conclave at New Delhi, and it was unbelievable to see so much research and patents happening in dentistry. In fact, when we hosted the conference, we thought probably there are about 500, 600 patents in dentistry in our country. But we were astonished to know in dentistry in India, there are close to 8,000 patents which have already taken place. The only unfortunate part is that these patents have not gone into commercialization because people don't know how to get them funded, how to put it to a reality, and how to be a good entrepreneur. So IDA arranged this conference, organized this conference for this purpose. We brought clinicians, engineers, financiers, ministry, Shark Tank, everybody together so that the younger generation today has opportunity to do not only clinical dentistry, but entrepreneurship in dentistry too. The future is digitization, intraoral scanning, 3D printing, new printing materials, new digital workflows, and probably the biggest of them all is artificial intelligence. As I stand here representing the Indian Dental Association with the voice of close to 100,000 members, I assure you that IDA stands committed to improving public oral health and providing quality healthcare to the people of India. It gives me a great pleasure in sharing that while the independent India is celebrating the Azadi Ka Amrit Mahotsav, and with that, IDA is celebrating 75 years of its existence. The Indian Dental Association, to usher in the new era of future dentistry, will be hosting the International Digital Dental Conference in June in Mumbai. I invite all of you for this event. It is being organized with the Digital Dental Society of Europe. With these words, I would like to express again that I thank and congratulate Dr. Himanshu, the team of Innovative Education and Scientific Research Foundation, and the organizing committee for conducting a very successful conference. The conference will have lots to take home from the galaxy of star speakers and numerous pre-conference courses. I wish the organizers all the very best for all their future endeavors. And I would praise their journal, the quality of journal in the last few years, ever since Himanshu took over as editor-in-chief, has gone up many scales. So please continue with that good work, and I hope in your other future endeavors also you succeed. Let us all pledge to make IDA the world leaders of tomorrow. Jai Hind, Jai IDA. Thank you.
Thank you, Dr. Chuks. Now, I would like to invite all the dignitaries to release of Volume 9 and Issue 1 of our International Journal of Oral Health Dentistry in open access peer-reviewed index scholarly journal, which is completed 8 years of successful on-time publication. So,
Thank you all. Can we have slides, please? It's in proud and privilege we have Professor Dr. Hemchandra sir, who is the Vice Chancellor, Hemvati Nandan Bahuguna Medical Education University, Dehradun. He is a member of National Medical Commission and member of governing body of National Board of Examination in Medical Sciences. And he was head of Department of Hospital Administration and Medical Superintendent, and was also served the Army Medical Corps. He was the only member in the field of hospital or health administration in India conferred internationally with a fellow of Royal College of Physicians, FRCP, by Glasgow, Edinburgh, and London. Sir has paper published more than 170 on international and national platforms, and he has various scientific deliberations, like he has presented more than 100 paper presentations, 12 book publications, and organizing many CMEs and training programs, more than 130. He has been awarded with a lot of awards like AHA Ratna Award, UP Ratna, Uttarakhand Ratna, Best Vice Chancellor, Corona Yodha Samman Award, and Certificate of Excellence Award. I would say for sir that a positive mindset brings positive things. With these words, I call upon Hemchandra sir for the word of wisdom, sir.
थैंक यू मैडम, थैंक यू वेरी मच। आप सभी लोगों को मेरा नमस्कार और गुरुजी को मेरा प्रणाम। आज के इस समारोह डेंटाकॉन 3 के मुख्य अतिथि के रूप में सर्वप्रथम मैं परम पूजनीय स्वामी अवधेशानंद गिरी जी को अपने और अपने विश्वविद्यालय की ओर से सादर नमन करता हूँ। और ये मेरा आज सौभाग्य, इट्स माई ग्रेट प्लेजर टू बी हियर एंड शेयरिंग द डायस विद सच ए रेनाउंड एंड द इमरिटस पर्सनालिटी along with the other guests on dais. In addition to that, my dear friend, class fellow, Dr. Rajiv Kapoor, we were sitting together, they could not recognize till such time. There was some suspicion within the mind of both of us that these particular names are very convenient and familiar to us. Then we introduced to each other, sir. Our last meeting was the 40 years in King George's Medical College, Lucknow. We are the class fellow. Thank you, Dr. Raju, for giving your appearance special. I am really delighted and happy today with my old memories. And the founder chairperson, Dr. Gupta sir, and Amit Gupta sir, Dr. Jha, and of course the bone of this organization, the principal Dr. Himanshu and Dr. Anirudh, and the faculty members, professor of department, senior resident, junior resident, and other officers and the employee of this one of latest affiliated dental college of the HNB Medical University, Dehradun. Extend again and again my hearty very good morning to all of you. At the outset, I would like to congratulate the organizing committee headed by Dr. Himanshu and his team for organizing this conference in the state of Uttarakhand, and that is the holy city, Rishikesh here. So I have been to this place, but as in the form of the Vice Chancellor of this prestigious institute, I am very proud of that with the help of the organizing team and the great effort of Dr. Aaron and Dr. Anirudh. We further came together in the form of that this Seema Dental College has become the first affiliated college of the HNB Medical Good. I'm very thankful for all of you for having considered us and to be associated as an affiliated college. Now we have become a part of the family. Most welcome and thank you very much. And of course, without saying anything, that the symbiotic assistance, symbiotic system of the cooperation and the support will continue lifelong, whether a present Vice Chancellor myself will not be there because they will keep on changing in the future, but the relation will remain forever, forever. My best wishes for this cooperation and the support. And of course, I am very grateful that today I have been invited as a guest of honor. I am a part of family now has become. I am very happy that it is learned to me that more than 800 delegates have been registered for this particular programs, and that is the offline and the online. I would like to tell one secret thing here also, because since I joined the KGMC in 1977, when Dr. Rajiv also joined, we created an history basically. Myself and one dental BDS student remained together in a room for a period of 1.5 years. That is a unique example of the KGMU and other places, I will tell you, because the pairs are usually dental to dental or medical to medical, but Dr. Hemchandra and Dr. S.N.P. Gupta remained together for a period of 1.5 years in a single room in the old TG hostel of the KGMU. It's my great pleasure, and always I quote this particular instance to give the association, my association with the dental college. Dental specialty has become now quite advanced nowadays, I will tell you. And I am happy to be here all the time. 3 or 4 times I have visited this place. And the infrastructure and the main thing is the faculty of this particular prestigious institute is par excellence. Not only that, it's my part or my affiliated university, because I have seen the outcome, the student or the PG resident, those who have passed from this place, interacted at many places throughout the country. And it gives me immense pleasure that we are very proud that such an institution is located in the state of Uttarakhand, that is in the Rishikesh. So I think we all here basically will be there for 2 days conference, and the deliberation I will request to the organizers and the participant and the my dear student also, be interactive with each other and give the recommendation at the end of the second day, so that if any more advancement in the college or in the state of Uttarakhand in the form of the public health can be done or delivered to the public, starting from the Uttarakhand definitely, that I have also learned that the delegates from all over India, they have visited to this place, but initiation has to be from the state where this conference is being held at the moment. So we are responsible for that. I think the deliberation will come out in a fruitful way, and those will be forwarded to us as a part of the government basically. And if in case the assistance of the university, I promise you, any assistance or any help from the university is required from my side or the state government side, I can also assure you on behalf of the state government, we are always with you for the advancement of the dentistry in the state of Uttarakhand and the country. So at the end, I am again thankful to Dr. Aaron and Dr. Gupta and the organizing committee for having organized such a beautiful program today. Especially, I am very obliged that to be with the associated and with the sharing the dais with the Sri Swamiji today, and I hope we will continue to meet in future and getting his blessing always and always being seated in the state of Uttarakhand. Thank you very much. See you again. Thank you. Namaskar.
Now it's the time of so many months. It is being compiled in the souvenir, and I request all the dignitaries to release of souvenir of Dentocon 3. Can we have a round of applause, please?
Now I request Param Pujya Swami Avdeshanand Ji Giri Maharaj assisted by Dr. Himanshu Aaron sir, to felicitate our guest speakers and all dignitaries on dais and conveners. Thank you. I request Dr. R.K. Gupta sir also to join. Yeah. I request Dr. Amit Gupta sir to come forward. Yeah. Dr. Amit Gupta sir. Dr. Jyotsna Seth, ma'am.
I would request Dr. Nikita ma'am, please.
Now, guest speakers for the session, Dr. Raju Chuk sir, Dr. Nimfia Pandit ma'am, Dr. Nimfia Pandit ma'am, Dr. Rumpa Vig, Dr. Rumpa Vig, yes, okay. Dr. Prashant Bhasin sir, Dr. Shalu Rai, Mr. Rakesh Pandit, Dr. Shalu Rai, Mr. Rakesh Pandit, Mr. Rakesh Pandit, Mr. Ajay Garg, मैंने क्या करना है? Thank you all. Thank you all. Can I request you all to have a round of applause, please? Don't discontinue. Now I request Dr. Himanshu sir to come for felicitation by Swami Avdeshanandji Giri Maharaj. Thank you all. Now I request Pujya Swami Avdeshanand Giri Maharaj, Juna Pitheshwar, Acharya Mahamandleshwar, to come and give our blessings. He is the chairman, Hindu Dharam Acharya Sabha, spiritual head of Sri Panchadharma Juna Akhada, referred as Acharya Mahamandleshwar. Spiritual head is a leader of 1.4 million sannyasis and more than 10 million devotees. Heads Prabhapati Premi Sangh, which is more than 250 branches and 10 million followers. Head of Sammanave Trust Haridwar, which is famous Bharat Mata Mandir and has a branch 7 countries. Learned and a prolific writer, author of about 60 books and written extensively on various aspects of Indian spiritual philosophy. His Holiness was awarded DL in 2008 by prestigious Vikram University. Cheerful, compensate and pleasing personality.
Thank you. कल्याणी मोक्षदा भगवती भागीरथी गंगा के तीरे, जहाँ प्रत्येक जीव के कल्याण के लिए माँ भागीरथी गंगा पहली बार गिरिकंदराओं की ओट से निकलकर धरती को स्पर्श करती हुई इस पवित्र ऋषिकेश को तीर्थ के उच्चतम प्रतिमान प्रदान करती है। ऐसी इस दिव्य तीर्थ ऋषिकेश नगरी में सीमा डेंटल कॉलेज एंड हॉस्पिटल के इस सारस्वत सभागार में डेंटोकॉन 3 कॉन्क्लेव के अवसर पर इस संपूर्ण परिसर के रचनाधर्मी आदरणीय आर.के. गुप्ता जी, प्रिय अमित गुप्ता जी, और इस अवसर पर नेशनल प्रेसिडेंट इंडियन डेंटल एसोसिएशन एंड मेंबर डेंटल काउंसिल ऑफ इंडिया आदरणीय डॉक्टर राजीव चुग जी, हेमवती नंदन बहुगुणा विश्वविद्यालय
मेडिकल एजुकेशन यूनिवर्सिटी के माननीय वाइस चांसलर ऑनरेबल डॉक्टर हेमचंद्रा जी, इस संपूर्ण आयोजन के रचनाधर्मी शिल्पीकार आदरणीय डॉक्टर हिमांशु एरन जी, और बहुत दूर से आए इस अवसर के लिए आदरणीय डॉक्टर एस झा जी, इस सारे आयोजन को गति दे रही दोनों बहनें डॉक्टर ज्योत्सना सेठ, डॉक्टर निकिता पंडित, और इस अवसर पर आप सब भिन्न भिन्न स्थानों से चलकर आए मान्य अतिथि, सीनियर रेजिडेंट, जूनियर रेजिडेंट और विविध क्षेत्रों की गणमान्य विभूतियाँ, बहुत वर्षों से डेंटल कॉलेज की यहाँ की वे गतिविधियाँ जो मुझे प्राय भिन्न भिन्न स्थानों पर सुनने को मिलती हैं, वे सभी ऐसी गतिविधियां हैं जो कीर्तिमान कही जा सकती हैं, उपलब्धियां कही जा सकती हैं, या उत्तराखंड के लिए एक बड़ा महत्वपूर्ण अवदान, योगदान कही जा सकती हैं। वे सारी गतिविधियां ऐसी हैं जो एक प्रकार से केवल एक्टिविटीज़ नहीं हैं, वो प्रेरणाएं हैं और वो ऐसी इंस्पिरेशंस हैं जो गौरवान्वित करती हैं हम सबको कि हमारे उत्तराखंड में एक ऐसा संस्थान दंत चिकित्सा के लिए जो चर्चित है पूरे देश में, और यहाँ से निकले वे सब प्रोडक्ट, यहाँ की विभूतियाँ पूरे देश में विविध प्रकार की सेवाओं में संलग्न है। भारतीय दंत चिकित्सा परिषद द्वारा अनुमोदित यह संस्थान यहाँ से बड़े कीर्तिमान के साथ जुड़ा है। हम सबके पास यहाँ की विभूतियाँ, दैवीय क्षमताएं हैं, हम सबके पास भारतीय दंत अपूर्व योग्यता है, अतुल्य ऊर्जा है, वे बड़ी वैसी सामर्थ्य है जो देवताओं को, हम सबके पास ऐसा कुछ है, दैवीय क्षमताएं हैं, हम सबके पास ऊर्जा, शक्तियाँ, विभूति, अपूर्व योग्यता है, अतुल्य ऊर्जा है, वे सब वैसी सामर्थ्य है जो देवताओं को उपलब्ध है। हमारे पास ऐसा कुछ है हम सबका जीवन, जिसमें हमारी ऊर्जा, शक्तियाँ, विभूति, योग्यता, पात्रता, सामर्थ्य देवताओं से कम नहीं है, और हमारे पास में अपार संभावनाएं भी हैं। हमारे पास जो पॉसिबिलिटीज़ हैं वो एंडलेस हैं, और नॉट ओनली द एंडलेस पॉसिबिलिटीज़, अपॉर्चुनिटी टू। तो हमारे पास बहुत अपॉर्चुनिटी भी है, बस बात यह है कि हम उनको किस तरह से कैश कर पाते हैं, उन्हें हम कैसे जगा पाते हैं। और ऐसा तब अधिक होता है जब व्यक्ति अपनी ऊर्जा को पहचानने के लिए, अपने सत्य और अपने अस्तित्व को अनुभूत करने के लिए एक बार भीतर झांक कर देखे। अगर वो स्वयं को समझ सके, अपने अस्तित्व को, अपनी सत्ता को, अपने होने के अर्थ और अपनी सारी शक्तियों को अगर एक बार जान सके तो बड़े कार्य कर सकता है वो। आप चिकित्सा क्षेत्र के लिए भगवान ने पैदा किए हैं और उस दिशा में आप बड़े कीर्तिमान गढ़ेंगे, या आपकी उपलब्धियां अथवा आपका योगदान अथवा आपकी सहभागिता निसंदेह लोक कल्याण में एक बड़ी भूमिका निभाएगी। पर अगर हम अपने को पूरा समझ सकें तो हमारे अन्य और भी योगदान हो सकते हैं, समाज के लिए, देश के लिए और पूरे संसार के लिए। भारत ने बहुत पहले उन्नत कोटि की चिकित्सा दी है, शिक्षा दी है। भारत विज्ञान का क्षेत्र रहा है। आज पूरे संसार में भारत की चर्चा है, भारत की औषधियों की, तकनीक की, विज्ञान की, विशेषकर अध्यात्म की और योग की। योग दिवस के माध्यम से भारत के योग को जाना पूरे संसार ने, विशेषकर कोरोना काल में। भारत के आध्यात्मिक विचार, यहाँ की औषधियाँ, यहाँ का योग और विविध विधाएं, प्राणायाम आदि की, जिनसे इम्यूनिटी बढ़ाई जा सके, जिससे संबल, आश्रय, अवलंब मिला लोगों को, एक ढाढ़स बंधाया भारत के योग ने। तो हम भारत के प्राणी ऐसे ही हैं। आज जब प्रेसिडेंसी भारत के पास है G20 की, उस G20 की प्रेसिडेंसी के द्वारा भारत आकर संसार भर के अनेक शासक, प्रशासक, अभियंता, चिकित्सक, वैज्ञानिक, विचारक, आविष्कारक चकित हैं भारत की बौद्धिक संपदा देखकर, यहाँ की ज्ञान संपदा देखकर, यहाँ की वे सारी चीज़ें। भारत ने ये कहा है इस प्रेसिडेंसी के माध्यम से कि एक ही फ्यूचर है हम सबका, वन फ्यूचर, वन वर्ल्ड, वन फैमिली। इस G20 की प्रेसिडेंसी के द्वारा हम ये बता सके कि पूरा संसार एक है, एक ही परिवार है और हम सबका एक फ्यूचर है। हम सबके उस फ्यूचर में उन्नतता और एकता, समन्वय, विश्व शांति, आपसी सौहार्द और एक बड़ी उन्नति का मार्ग कैसे निकल सकता है। तो भारत इसके माध्यम से कुछ आध्यात्मिक सूत्र भी दे रहा है पूरे संसार को। तो जहाँ आप यहाँ दंत चिकित्सा के माध्यम से बड़े कीर्तिमान स्थापित कर रहे हैं, निसंदेह यहाँ कुछ और भी सीख रहे होंगे। यहाँ के परिवेश से, यहाँ के वातावरण से, यहाँ के वायुमंडल से आपको बहुत कुछ मिल रहा होगा। चूँकि भारत की बड़ी पवित्र, दिव्य और ऊर्जा संपन्न नगरी है ऋषिकेश, और इस संस्थान को संचालित कर रही जो व्यवस्था है वो भी बड़े आध्यात्मिक है, विशेषकर गुप्ता फैमिली और आप सब लोगों के द्वारा इस सृजित डेंटोकॉन 3rd इस कॉन्क्लेव में आकर मैं आनंदित हूँ। आई एम वेरी हैप्पी टू बी हेयर। मेरी बहुत बहुत ब्लेसिंग्स, शुभकामनाएं आप सबके लिए। और विशेषकर जो अभी ये प्रकाशित हुए जर्नल, इनमें भी सहायक सामग्री, इसमें भी एक सपोर्टिव, एक जो विचार हैं वो सहायक बनेंगे। मैं आकर आनंदित हूँ। इस संस्थान के उन्नयन उत्थान के लिए, सीमा डेंटल कॉलेज हॉस्पिटल के उत्कर्ष और इसकी अनंत ऊंचाइयों के लिए और आपके उज्जवल भविष्य के लिए मैं प्रभु से प्रार्थना करता हूँ। मेरी बहुत बहुत शुभकामनाएं। हरि ओम।
Now our inauguration ceremony is about to end. With our vote of thanks, I would request Dr. S.S. Jha, who is the President IESRF, Vice Secretary General Asia Pacific Society, Foot and Ankle Surgery, Past President Indian Foot and Ankle Society, Patron and Founder, Past President Indian Orthopedic Rheumatology Association, and he is also President IESRF. With these words, I call upon Dr. S.S. Jha, sir, to propose the vote of thanks for the event.
मित्रों, मैं स्वामी जी से अनुमति चाहूँगा कि मैं अपना ये थैंक्स गिविंग संभाषण, अगर मैं इसे ऐसा कह सकूं, तो अपने प्यारे विद्यार्थियों से शुरू करूं। शिक्षक होने के नाते और बरसों बरसों क्लासरूम टीचिंग करने के नाते जब हमारे विद्यार्थी हमारे सामने होते हैं तो मुझे लगता है मैं बहुत ही मोटिवेटेड होता हूं कि कुछ संवाद स्थापित करूं। मैं शायद आपको कुछ सिखा पाऊं या ना पाऊं, परंतु आपसे भी सीखने की उम्र हमारी अभी बची है। IESRF के प्रेसिडेंट होने के नाते मैं भी सहभागी रहा हूं इस के आयोजन में, और हिमांशु जी के साथ हम सबों ने मिलकर इसे इस तरह से आयोजित किया है। मैं सोचता हूँ कि अगर मैं IESRF का प्रेसिडेंट नहीं भी होता तो मैं इस फ्लोर से आ रहा था, वहाँ देखा ऑर्थोपेडिक वर्ड लिखा हुआ है। मैं ऑर्थोपेडिक सर्जन होने के नाते समझता हूँ कि कहीं ना कहीं हमारा एक हिस्सा आपसे जुड़ा है, और यूँ कहे तो सारे दांत के रूट्स तो उसी हड्डी में हैं। परंतु मैं जिस उम्र में हूँ, इस उम्र में डेंटल डीके का पेशेंट भी हूँ, और डेंटल डीके की बात आती है तो मुझे लगता है कि अपने डेंटल साइंसेज में रिहैबिलिटेशन, गुरुजी ने कहा योगा, इन सारी विधाओं की आवश्यकता है, और हमें कोमॉर्बिड कंडीशंस के बारे में भी जागृत रहने की आवश्यकता है। तो मैं अपने प्रिय विद्यार्थियों को, वो चाहे अंडर ग्रेजुएट हो, पोस्ट ग्रेजुएट हो या रेजिडेंट हो, आप सबों का धन्यवाद ज्ञापित करता हूँ कि आप सभागार में न होते तो ये सभा नहीं होती। पूज्य स्वामी अवधेशानंद गिरी जी, जूना पीठाधीश्वर, आचार्य महामंडलेश्वर, सद्गुरु दिव्य ज्ञान रूपी दीपक से अंतःकरण में पड़े अज्ञान के अंधकार को हटाकर परमेश्वर के दर्शन का मार्ग प्रशस्त करते हैं। परम स्नेही संत श्री पूज्य स्वामी अवधेशानंद गिरी जी, आपके दर्शन मात्र से सुख की प्राप्ति होती है। आप दुख को हर लेते हैं और पाप का विनाश भी करते हैं। स्वागतम ओ महाभागा, प्रियं किंग में अतः परम, सानिध्यम क्षण मात्रमपि सर्वथा ही पुण्यप्रदम। हे महाभाग्यशाली आचार्य महामंडलेश्वर, आपके पुण्यप्रद सानिध्य से बढ़कर हमारा और कौन सा अभिष्ट हो सकता है। निश्चय ही यह क्षण यहाँ उपस्थित सबों के भाग्य का उत्कर्ष है। अहो भाग्यं नंद गोप ब्रजकोश आम, यन्मित्रं परमानंदं पूर्ण ब्रह्म सनातनम। जिस प्रकार नंदगांव के ग्वाल बालों के भाग्य की सराहना करते हुए ब्रह्मा जी कहते हैं कि धन्य हैं वे जिनके साथ परमानंद परमात्मा ही उठते बैठते और संवाद करते हैं, उसी प्रकार अपने बीच मुख्य अतिथि के रूप में अनंत श्री विभूषित महामंडलेश्वर स्वामी अवधेशानंद गिरी जी महाराज को पाकर हम सभी अपने सौभाग्य पर फूले नहीं समा रहे हैं। महामंडलेश्वर जी, एक बड़ी विडंबना है। आजकल आप सुनते होंगे कि किसी अस्पताल में किसी मरीज की मौत हो गई और डॉक्टरों के साथ बड़ा ही दुराचार किया गया। कहने को तो कहते हैं कि इस डॉक्टर भगवान का दूसरा रूप है, परंतु आज आपकी उपस्थिति में मैं कहना चाहता हूँ, यह तो व्यक्तिगत सोच की बात है कि डॉक्टरों में आप भगवान को पाएं या नहीं पाएं, परंतु हमें आप ऐसी दृष्टि दें ताकि हमें लगे कि हमारे सामने बैठा हुआ मेरा हर मरीज भगवान का स्वरूप है, ताकि अगर हम भगवान की सेवा करने बैठे हैं तो संभवतः हम कभी कोई गलती नहीं करेंगे। और मैं आप सबों का ध्यान आकृष्ट करना चाहूँगा कि श्रीमद्भागवतम में वेद व्यास ने कहा है, एतावानेव लोकस्मिनः पुंसः स्वार्थ परस्मृति एकांत भक्ति गोविंदे यत्र सर्वत्र दक्षिणम तदिक्षणम। So it means develop love for God, and in this devotion see God in everyone. बहुत बहुत धन्यवाद नहीं कह सकता हूं। आपका आशीर्वाद यहाँ बैठे सारे लोगों को भविष्य में भी मिलता रहे और मानव कल्याण की ओर जो हम अग्रसर हैं उसमें यह बहुत बड़ा योगदान होगा। Well, coming to our respected guest, Dr. Rajiv K. Chugh, Member Dental Council of India and National President Indian Dental Association, being the head of the family, if I can say so in your capacity as the National President of IDA, we are so happy and thankful to you for your valued presence during the inaugural ceremony. You are a beacon and torchbearer for the learned audience and faculty members, and I am confident you will continue to inspire us. Also, we are thankful for your likely to be delivered N.K. Agrawal oration, which talks on irrigants in endodontics. Our next guest, Dr. Hemchandra, Honorary Vice Chancellor of Uttarakhand Medical Education University, Dehradun. Sir, heading a medical education university is a matter of great pride, as the dental curriculum is governed and executed through your good offices apart from other medical institutes. And I have learned that you have always kept a watchful eye on in encouraging the PG and undergraduate faculties for providing their best. I am once again grateful for accepting to be present and guide us. Dr. R.K. Gupta, Founder, President, Seema Dental College and Hospital, Rishikesh. That you have fathered this institution tells us about your farsightedness in conceptualizing this institution and must have had Herculean task performed in bringing up this premier institution, which is serving as the first postgraduate institute in Uttarakhand having master program in 6 specialties. Our morale is at its peak because of your presence, and we are really thankful. Well, Dr. Amit Gupta, Chairman, Seema Dental College and Hospital, and Patron Dentocon 3. Well, dear Dr. Gupta, as far as Patron of Dentocon 3 is concerned, we are fellow travelers in the same boat. While you represent SDCH, I represent IESRF. Being chairman of SDCH, you have added responsibilities in providing all the infrastructural facilities of this institute, and I really acknowledge your dynamic persona. Thank you very much. Well, talking about Himanshu Aaron, the Director, Principal, Professor, Head of Oral and Faciomaxillary Prosthodontics and Implantology, and Convener in Chief of Dentocon 3. I am personally deeply thankful to you for collaborating with IESRF in organizing this Dentocon 3. Your active association with IESRF has been at the root for developing this concept of organizing Dentocon 3. I must acknowledge the invitation to me and to my wife. We at IESRF have always rejoiced your achievement in various academic and social fields, and we are greatly enthused by your dynamic presence in leading the dental fraternity of IESRF also. How can I thank you for all that you have done to IESRF and SDCH? This state-of-art dental institute with all modern facilities is a world-class hospital and teaching center because of all your endeavors. I am really grateful. Well, coming to the two Master of Ceremonies and Conveners, Dr. Jyotsna Seth and Dr. Nikita Pandit. Before I end it, I will like Mr. Rakesh Pandit to come to the dais. So friends, brains and beauties can coexist, and it cannot be better visualized than in you both. Without your efforts, it could not have seen such panoramic sights and the house, which I prefer to call a parliament of dentistry, so full and vibrant. Well, God bless you both. I, on behalf of all the participating delegates and faculties, would like to shower our thanks for being on toes for weeks and months. Lastly, it is, well, before that, I would like to say that Dr. Nikita and Rakesh Pandit had their marriage anniversary, but leaving that marriage anniversary, they were here. He was working in Delhi, he was here. So I would like to present to both of you for extra blessings from Mahamandaleshwar on the eve of your marriage anniversary. And I again seek blessings to this golden girl, Dr. Jyotsna Seth. Dr. Jyotsna Seth Mahamandaleshwar ji also has been burning her midnight candles for the success of the conference. So thank you and thank you very much. Lastly, it is my dear delegates physically present and especially the 400 online delegates along with the larger community of undergraduate and postgraduate students, faculties, and moreover all the staff of the STCH and the print and visual media. I am highly thankful and grateful to you all once again. Friends, let us live, learn, and you all make us laugh again and again. Long live Dentocon and Seema Dental College and Hospital, Rishikesh. Thank you very much.
Thank you, sir, for so inspiring words and appreciating our work. Now I would request you all to please rise for the national anthem. Thank you all for your time. And now we have an N.K. Agarwal oration lecture here itself. I would request everybody to stay here for the N.K. Agarwal oration, which will be given by Dr. Rajiv Chuk, sir.
Good afternoon. I request the audience to please take their seats so we can continue with the next session of the keynote speakers. The next session is the Dr. N.K. Agarwal oration by Dr. Rajiv Chugh, a stalwart in the field of endodontics. The chairperson for this session will be Dr. Manoj Mittal sir, who is current Vice Chancellor, Bhabha University, Bhopal, and he is also Principal Professor Head, Department of Periodontology, Bhabha College of Dental Sciences, Bhopal. So the next session, Dr. N.K. Agarwal oration, which will be delivered by Dr. Rajiv Chugh, a stalwart in the field of endodontics. The first chairperson for the session will be Dr. Manoj Mittal, sir. Sir is currently Vice Chancellor, Bhabha University, Bhopal. He is also Principal Professor and Head Department of Periodontology, Bhabha College Dental Sciences, Bhopal. He is an academic and he has academic and research tenure of more than 21 years. He is on board of Examiner and Academic Council of multiple universities such as Bhabha University, Barkatullah University, and many others. He is Chairman, Board of Studies, Ethical Committee at SRK University, Bhabha University, and Devi Ahilya University. We welcome you, sir, to our college and Rishikesh, and are thankful to you for taking out time and gracing the occasion. Thank you, sir. The second chairperson for the session is Dr. Jyotsna Seth, Professor, Department of Prosthodontics, Crown and Bridge, Seema Dental College and Hospital, and she is convener for this Dentocon 3 conference. She is an astute academician with a plethora of publications and research work to her credit. I request Dr. Jyotsna Seth to come on the dais and speak about the Dr. N.K. Agarwal oration and the speaker for the present session. Thank you.
It's a proud and privilege to tell us about the Professor Dr. N.K. Agarwal oration. Professor Dr. N.K. Agarwal name ring loud in academic circles, both in India and abroad. He received his master degree in prosthodontics from University of Detroit, Michigan in 1962. His academic career spans more than 40 years, in which he is the founder, head of Department Prosthodontics, Dean Dental Faculty, and Vice Principal of King George Medical College, Lucknow. He was a visiting professor at the School of Dentistry, New York from 1974 to 1976. He is a founder member of the prestigious Indian Prosthodontic Society and has served as its president twice. He has been an advisor from India for the FDI, and his efforts as the executive committee member of the DCI were instrumental in the establishment of independent faculty of dental science in all government dental colleges, notably Jaipur, Patiala, Srinagar, Goa, Rohtak, Guwahati, and Delhi. ICD Section 6, India, Sri Lanka, Nepal section constituted ICD Dr. N.K. Agarwal for Best Outgoing PG Student in Prosthodontics at Seema Dental College and Hospital, Rishikesh, Uttarakhand. With these words, I welcome Dr. Rajiv Chugh, sir, who is going to give us Professor Dr. N.K. Agarwal oration, and it's a privilege to introduce Dr. Rajiv Chugh, sir. He is the President-elect IDA National Head Office 2022-23, Member Dental Council of India since 2015, Founder, Secretary Journal, Indian Academy of Restorative Dentistry. He is also Editor-in-Chief Product Profile, an official publication of IDA, and Editor-in-Chief in UP Dent. He is the Chairman Reception Committee, Sanitary Celebrations IDA Head Office, and the Vice Chairman of Pere Forte Canby India section. Dr. Chugh is an endodontist of repute and has been in private practice daily for more than 38 years. And he is an alumnus of KGMC, and he is trained at the University of Pennsylvania, USA in microscope surgical endodontics, and has been a member of American Association of Endodontics. He has various fellowships to his credit: Master Fellow of ICD, Member National Academy of Medical Sciences, Academy of Dentistry International, Diplomat, WCOI, and Pere Forte Academy. He has been in an editorial advisory board and editorial board of various reputed journals, and he has also bagged a lot of awards like Best State Branch President in the country by IDA Head Office, first recipient worldwide of the ICD Distinguished Service Award, recognized by IDA Head Office publication, Oral Health as a Dental Ratna, and Dental Ratna Award by Sinodent. He has been given a keynote speakers in the various national conferences and conducted many CD programs. And he is recipient of the prestigious Dr. M.L. Soni oration and Professor C.P. Goyala oration by the IDA. With these words, I call upon Dr. Rajiv Chugh, sir, for N.K. Agarwal oration. Can we have a round of applause, please?
Thank you, Dr. Jyotsna. Good morning, friends. It's my proud privilege today to deliver the Dr. N.K. Agarwal oration at this Dentocon 3. I'm thankful to Dr. Himanshu Arian, Seema Dental College, and Innovative Education and Scientific Research Foundation for awarding me this very prestigious oration. I happen to be a student of Dr. N.K. Agarwal. It's been my, I would say, proud privilege, and I'm blessed that he taught me during my graduation days, because I didn't postgraduate in prosthetics, so I couldn't study with him during my post-graduation days. But nonetheless, I was associated with him throughout my tenure in the dental college, KGMC. I was there from 1977 to 84, and he was a kind of a fatherly figure for all of us. He was a great academician. I would say a little ahead of the times at that time, because that much of advanced education was still not available in India. And he was highly educated from United States. But he tried his best to impart his knowledge to all his students, and we learned a lot. And not only a good academician, he was a great human being also. So I remember him today when we are delivering this oration in his memory, and I hope wherever he is, his soul may rest in peace, and he keeps blessing all of us. And I think the prosthetic department under his leadership in KGMC became one of the best departments in the institution, and not only that, one of the best departments in prosthetics in the country at that time. So my topic which has been given today is endodontic irrigants. And before I do this, I would like, since I am president of the Indian Dental Association, I'll just like to share with you that like our 75th year of independence, the Amrit Mahotsav we are also celebrating 75th anniversary of Indian Dental Association. Recently, we celebrated the 100 years of dental education in the country in 2020. At that time, it was COVID, so we could not celebrate in a big way, though I tried my best, being the chairman of that committee, to organize a lot of webinars at that time. When I say centenary of dental education, that means that in 1920, the first dental institution, not only in the country, but in 125 dental institutions in the country. And you are lucky that you are part of one of the best institutions in the country today, studying here in Seema Dental College. So coming back to the topic on endodontic irrigants, the principles and the rationale of endodontics has not changed over the years, though endodontics has been in practice for many years now, more than a century. Still, diagnosis, instrumentation, obturation, and restoration are the main steps in any endodontic procedures. And any tooth which needs endodontic treatment has a pulpal involvement and periapical lesion, and has to be endodontically treated. And the main aim of any endodontic treatment still stays the same, that we have to reduce the irritants, which are the microorganisms within the root canal system. We have to make sure that those microorganisms which are existing in the canal space, either they are eliminated completely, or they are not, they don't remain viable within the system. And also we have to ensure that they do not cause reinfection, that our root canal should not get recontaminated. Though many advances have taken place in endodontics over the years, when we did our dentistry, I did my MDis in 1984, there were no rotary instruments, we used to do hand instruments. But for today, everything is rotary. Most of it is rotary instruments. Hand instruments are used very, very sparingly. But the science has evolved. There was no microscope, no magnification. Today, you can't imagine doing any endodontic treatment without magnification. The main objective still remains the same, that we have to remove the microorganisms which cause either infection or recontamination, leading to retreatment. And there were three principles of shaping, cleaning, and obturation. And the main aim was to preserve the periodontal tissues and stay within the confines of the root canal system. We know the root canal system is not a, when I say root canal system, it doesn't mean only a root canal, or this root canal does not, or the pulp doesn't exist only in a canal space which is a straight line canal or just a small space like a tube or a tunnel, but it's a much complex system. And the pulp is within the dentinal tubules. We have dentine all around the pulp, and these dentinal tubules are the ones which house the microorganisms in that. And the dilemma is that when we start preparing the root canal system, when we start removing that pulp tissue which is infected, we create something called smear layer. So that smear layer does not allow any endodontic treatment to be successful. So the whole concept is not only removing the pulp tissue, the root canal has to be treated till the dentinal tubules level. We have to remove the smear layer. Unless until we do that, the restorative material will not adhere to first the dentinal tubules housing the bacteria will not be removed, the bacteria won't be removed. Second is the obturation material cannot bond to the dentinal tubules. So if a root canal, if you look at a tooth, it doesn't look like in a radiograph. When you look, you don't see those accessory canals, lateral canals, and all these small fins, etc. in that. So it's much complexer than this. So looking at this, you wonder how will my root canal endodontic treatment treat all that? How will it reach all those places where the pulp is existing? But mind you, in last 1 century, more than a century, ever since we've been doing endodontic treatment, the endodontic treatments have been successful because we have been able to remove all this pulpal tissue which is existing in this canal system. I have always start my presentation with this X-ray. This is a radiograph, not a RVG. It is not a digital radiograph. This is more than 30 years back when we had hand instruments. There were no rotary instruments that time. You can see a patient coming with endodontic filling, and then this was all manual obturation, manual condensation which was done. And though the X-ray is not very clear, the whole periapical lesion healed by only mechanical preparation and hand obturation. So what is endodontic treatment? Endodontic treatment is in most cases done when the pulp is already infected. Very rarely we do intentional endodontic treatment. So most of the time it's a infected pulp, and it's basically an anti-infection therapy. Means the pulp is already infected, and now we have to get rid of that infection. The pulp is infected, we have to remove that infected pulp, and we have to make sure that that infected pulp, if left behind, can be a source of infection for the adjacent tooth or the surrounding tissues around the tooth which is infected. So the endodontic treatment is targeted against bacteria, but bacteria are many kinds of bacteria. They are not only one species which is existing. It's a very complex system, polymicrobial infection. There are anaerobic bacteria, gram-positive, gram-negative bacteria, if you look at the whole list of bacteria, there are more than 600 species of bacteria which are found in the root canal system. So the whole treatment is targeted against this polymicrobial infection. And these bacteria not only cause infection in the periradical inflammatory response, but they can also lead to abscess and cellulitis. So if any infected pulp not treated can eventually lead to abscess and cellulitis. So there are two kinds of endodontic treatments which are done, one is called active, where the root canal is already infected, and the second is preventive, where the tooth is still not infected, the pulp is still vital, and then you do preventive treatment and vital pulp therapy and avoid the endodontic treatment, in the sense that you don't have to do the canal preparation and obturation, etc., but you can do vital pulp therapy, preserve the pulp, and avoid doing root canal treatment. So what is the rationale of endodontic treatment? The rationale from day one has been that we have to remove all those bacteria which are present in the system, or as I said, you have to make them non-viable. So if the tooth pulp is vital, it can defend itself. It has a defense mechanism which can fight against those microorganisms as long as the pulp is vital. Once this pulp becomes non-vital, then the bacteria start growing in number, and at that stage, it is not possible for the tooth to defend itself. So any vital pulp therapy would mean that the tooth is not infected yet. Infection, if it happens, will lead to necrosis and asepsis. So the whole vital therapy would mean that if you are able to put a rubber dam, isolate the tooth, and do a vital pulp therapy, not allow it to get infected, you can still call repair. The pulp can repair to that extent. But once the sepsis has taken place, of course, rubber dam still has to be used, but it doesn't, that pulp doesn't heal then. Then it would need endodontic treatment, root canal therapy. So in those cases, then once sepsis has already set in, the endodontic treatment would be antisepsis treatment. And why do endodontic failures happen? Because of the microorganisms. As long as they remain in the root canal system, or if you do a root canal therapy, and if they were not eliminated completely, some bacteria were left behind, they will cause reinfection. Or your endodontic treatment was not up to the mark, your obturation was not there, the leakage has taken place, or post-endodontic restoration starts leaking or breaking down, that can cause recontamination. So that will, those microorganisms recolonize, and then they cause endodontic failure. So our best effort has to be to make sure the bacteria, as I said, either eliminate or non-viable, or you bury them within the canal system so that they do not cause any infection later on. This is a very important study which was done in 2001 by Peters. This is a sort of a landmark study which was done. What he did was he divided the dentine which is next to the infected pulp into 3 layers. Layer A, B, and C. Layer A is closest to the pulp, B is little further down, and C is the furthest from the pulp. And what he found, which was very, very important, is that even in the layer C, 62% of the bacteria were viable. Means when a canal gets infected, the pulp gets infected, the bacteria travel in the dentinal tubules not only to the layer A or B, they go as far down as to layer C. So what does this mean? That any endodontic treatment which we are doing is not limited or confined only to the pulp space. It has to be targeted to reach the microorganisms which are in layer A, B, or C. Sometimes it is not possible to reach deep down into these layers. So there has to be our treatment has to be such that we would either try to eliminate by using some kind of medicaments and by some irrigants, reach out there to eliminate them, or we bury them there so that they don't remain viable within the system. This is how the dentine looks like when it is invaded by the bacteria. And imagine you cannot even have a look at the dentinal tubules, they are not even visible. That is the layer of bacteria which are covering the dentinal tubules. Before we start with the treatment, remember what are the causes of these, what are the pathways for these bacteria or microorganisms to enter the root canal system. The most common, of course, is open cavity, means somebody has a carious lesion which is not attended in time, the cavity becomes deeper and the pulp gets involved. So this is an open cavity. Second possibility is dentinal tubules. What does that mean is that when we are doing any crown bridge preparation on a vital tooth, if bacteria can travel from the pulp to layer A, B or C, it's the other way around also, that when we remove the enamel, when we have removed the protective layer of enamel, the dentine is exposed. So any bacteria in the oral cavity can also travel from dentine into the pulp system. So what does that mean? How do we take care of that? That after any kind of preparation, prosthodontic preparation, crown or bridge in a vital tooth, you should always put a covering over the dentine. Don't leave the dentine exposed. Most of the times we don't realize if we are very close to the pulp and we are doing any preparation. When we take impression, we might be pushing those bacteria from the oral cavity within to the dentinal tubules and eventually reaching the pulp. So this is to be kept in mind, that you should always use antiseptic when you are taking impressions, and try to cover the dentine as early as possible after the preparation has been done, after the impression is also taken. Third is the gingival sulcus or pedial. How does the infection travel from there? If a patient has a pocket, periodontal pocket, there could be lateral canals or accessory canals. So sometimes the infection travels from the periodontal ligament or the infrabony pockets into the canal system. Fourth is from the bloodstream. Very rarely, that if there is an infection anywhere in the body, it can travel to this. This is more of a theoretical or academic thing. The possibility of such infection is very, very rare. Fifth is broken occlusal seal or faulty restoration. If the obturation at the canal orifices has not been done up to the mark, and if a restoration breaks, there's a possibility the canal system get reinfected. So always do good obturation, not only within the canal system, also at the orifice level. And your restorations should be very well done so that there's no risk of breaking down. Most of the times, what we have seen is if there's not only a faulty restoration, a faulty crown also after the endodontic treatment, where there are the margins are not being properly sealed, there's a risk of getting infected again. Or last is that if you get an infection in one tooth, it's not treated, it spreads to the next tooth. This is very, very common. And I'll show you an example of that. This is a X-ray of a patient who had only one tooth involved initially, but once it was neglected, other two teeth got involved. Again, endodontic treatment, and once the successful treatment is done, you can start, the healing has started, and eventually such a big lesion also resolved. You all learned basic principles of endodontic treatment in your student days that for any endodontic treatment you have to have good biomechanical preparation and obturation. The only thing is little modification over the years that it's not only biomechanical preparation, it is also chemico-mechanical preparation now. What does chemico-mechanical preparation means? That biomechanical preparation along with good disinfection. So isolation is very important. Rubber dam is a must. And besides that, the irrigants which we use to remove the infection from the tooth has to be effective against all the bacteria or microorganisms within the system. So there are two kind of intracanal medicaments which we use, which are called either irrigants or chelating agents. We'll talk today about the irrigants. In 1974, Schilder, who is considered to be the father of modern endodontic treatment, he said that to achieve any good endodontic successful treatment, instrument and canal preparation play a very important role. Why that is important is that if you have done a good canal preparation, you have removed all the pulp tissue and whatever the smear layer, etc. has been removed. If the canal preparation good, like a funnel shaped preparation, any irrigant which you use can reach the periapical tissues. And if the canal has not been prepared, the dentine stays infected, the pulp tissue remains within the system, and any amount of irrigant or whatever you use will not reach the periapical tissues till the apex of the canal, and the infected dentine stays within the system. So modified into that instrument shape the canal, it's the irrigants which clean and disinfect them. This is now you can say the rationale or principle of endodontic treatment today. The important thing is that why should irrigants be used? What is the role of irrigants? So there have been a lot of studies. This is a study in 1975 which says that if you don't use irrigants, 70% of the bacteria or debris remain within the root canal system, emphasizing on the need of irrigants. So irrigants not only remove the debris, they dissolve any leftover pulpal tissue, they lubricate the canals, and that help the irrigant also help reach the apical 1/3 of the canal system and the periapical tissues where the infection is there. But always remember that your root needle which is used has to be loosely used in the canal, and you should always have space for the flow back of the irrigant which is injected. Never use it under pressure, and you can enhance the effect of any irrigant if you use ultrasonic devices along with it. We'll talk about it more in detail. So irrigants can be used with, there are two aims. One is a mechanical aim and other is a chemical aim. What does it mean is that even if you use a normal saline which is not any chemical, it's you can say a kind of a water, sterile water which is used, there's some mechanical action which will wash out any debris from within the system. So this is not any chemical specific irrigation. So anything which will which you irrigate your canal with would remove some amount of debris. And the second is the chemical means that you are now using something which will not only mechanically remove the debris, but will also interact with the microorganisms and destroy them or make them non-viable. And this is specific to what chemical agent you use for irrigation. The chemical which are invariably used are used for their antimicrobial properties, and the other properties which are important for any irrigant is that they should be able to dissolve not only the soft tissue but also the hard tissue which comes in contact with that pulp, have a low toxicity. In case they come in contact with the periapical tissue, they should not be able to cause any toxicity or irritation in the periapical tissues or allergic reaction. They should be able to destroy the microorganisms, have low surface tension so they can penetrate into the dentinal tubules, lubricate the canals, and remove the smear layer. I'll tell you little more about the smear layer as we move ahead. The endodontic irrigants can be classified into non-bactericidal or bactericidal. So if the pulp is already vital, is not a non-vital pulp, then you have to use a chelating agent. But if it's already a non-vital pulp, then you have to first introduce sodium hypochlorite or any irrigant, and then proceed further with the instrumentation. They say that a good decision is based on experience, but experience comes from poor decisions. Because a lot of irrigants have been tried over the past century, and it has been found that sodium hypochlorite which is considered to be the best possible irrigant, is what is being used presently, and it was being used even a century back. A case of 4 root canals. So the irritants which are, as I said, there are 2 kinds of irritants, bactericidal or non-bactericidal. So among the bactericidal ones, the irrigants of choice today are using chlorhexidine gluconate or sodium hypochlorite. And we'll first talk about chlorhexidine gluconate. So chlorhexidine has been used for its antibacterial properties because it is very, very effective against any kind of anaerobes, gram-positive and gram-negative bacteria. And it is considered to be the tissues are very comfortable with chlorhexidine gluconate. It doesn't cause any allergic reaction. And in open apices, perforations, pediatric patients, it is very safe to use chlorhexidine gluconate. The only issue is that do not dissolve any hard and soft tissues. That's the only disadvantage with chlorhexidine gluconate. So any patient who has any allergic reaction to sodium hypochlorite or open apices, the irrigant of choice should be chlorhexidine gluconate. It has been used in different concentrations, and people have tried to use it for irrigation, and they have used it as an intracanal medicament and kept in the canal for a period of 1 week or longer, and they have found that it can eliminate all kind of infections from the root canal system. And as I said, different concentrations and different formulations have been used, and chlorhexidine has never showed any adverse reaction besides that it cannot dissolve the hard and soft tissues. As compared to that, when we use sodium hypochlorite, the biggest advantage of using sodium hypochlorite is that it can digest vital and necrotic pulp tissues, and it can also help us clean the hard tissues. So when we use 5%, 3 to 5% concentration is found to be most effective. And if you can increase the temperature of sodium hypochlorite to up to 60 degrees centigrade, the effectiveness of sodium hypochlorite also increases. How do you increase the temperature of sodium hypochlorite? Is that you take a syringe of sodium hypochlorite and keep the syringe in warm water and then use it for irrigation. Do not warm the sodium hypochlorite solution. So sodium hypochlorite, if you look at this study, this was done in 1918, more than a century back. At that time also, Austin found that sodium hypochlorite showed far greater tissue dissolving effect on necrotic than on vital tissues. So it's been in use for more than a century. So sodium hypochlorite is a time-tested irrigant with very successful results. And there's been a lot of studies to check the effectiveness with increasing the temperature. And it is found that low concentration with high temperature is as effective as using a high concentration sodium hypochlorite. It's always good to use sodium hypochlorite which is freshly made. These are a lot of studies, so I'm just quoting some of them. Tora Benajad is considered to be one of the top endodontists in the world today. He's the endodontist who invented MTA also. So all of them over the years have found that there's no match to sodium hypochlorite. The only thing is that the sodium hypochlorite has to be used very, very carefully in isolation, number one. Second thing is, it should not be used with pressure. It should not go into the periapical tissues. Come in contact is a different thing, but don't try to inject the irrigant into the periapical area. It can cause a lot of irritation, and I have personally seen a patient who had a mishap where the sodium hypochlorite was used by force. She developed necrosis, and I saw that tooth eventually getting necrosed, and in fact the tooth sort of dissolved in next few months. So there was nothing left there, and of course there was a lot of periapical damage to the patient. The solution should always be used passively, number one. There should be a lot of space for the backflow of the irrigant when you inject. The needle, as I said, should be loosely placed in the canal, and there should be space for the backflow of the irrigant with the debris. And thin needle with either 27 or 28 gauge needle should be used. And in case you find the canal is very thin and the needle doesn't go in, so in that case, fill the pulp chamber with the sodium hypochlorite, and with hand instrumentation try to take the sodium hypochlorite into the canal system and then widen the canal. Don't try to work in a dry canal. This is how the dentine looks when you use 1% sodium hypochlorite. This is 3% sodium hypochlorite, and this is 6% sodium hypochlorite. So if you use higher concentration for a long period, it can damage the dentine also. So be very careful handling sodium hypochlorite. You should use, as I said, freshly made sodium hypochlorite, and don't use it for too long. You can use it periodically, means that irrigate, then irrigate with normal saline, and then re-irrigate, and keep clearing out the old sodium hypochlorite. Don't leave it for too long in the canal system. As I mentioned about smear layer, we have to understand that the moment we start any root canal preparation, any endodontic procedure, when we start removing it's called the smear layer. Now this smear layer covers the dentinal tubules, so bacteria which are there within the dentinal tubules remain there, and a layer is formed over them. So that layer has to be removed. If you don't do that, you cannot reach the microorganisms. Even if you keep irrigating and do not remove the smear layer, then the microorganisms stay within the system. And not only that, if you keep the smear layer in the canal, the bacteria grow on that further and cause reinfection. Or this doesn't allow the obturation material also to seal the canals, because the obturation material will not adhere to the dentinal tubules. It adds to because the bacteria exist within the smear layer, so they have to be removed, otherwise they will cause inflammation and infection. And as I mentioned, it doesn't allow the obturation also to take place completely. This is how the dentine looks like when you do the instrumentation. That's how the smear layer looks like. You can't even have see any dentinal tubule. This is under magnification. And this is what the smear layer looks like. When you start instrumenting and remove the pulp tissue, the combination of the dentine, shavings, the pulp, this forms the smear layer and blocks the dentinal tubule. So this has to be removed. And the most effective way of removing this smear layer is to use aqueous EDTA. Aqueous EDTA is 17% is considered to be very effective against removing the smear layer. Different concentrations of EDTA has been tried, but now it is well established that 17% EDTA has to be used to remove the smear layer. And another important thing is because EDTA is a chelating agent, so it should also not stay in contact with the dentine for a long period of time. And it is considered that 1 minute exposure of dentine to 17% EDTA is good enough to remove the smear layer. This is how the dentine looks like when you use it for 1 minute. This is how it looks like when it is used for a longer period of time. It causes porosity of the dentine. The dentinal tubules break down, and this makes the tooth very porous and prone to fracture. So the treatment of choice is to remove smear layer is 17% EDTA for 1 minute. Root canal system for treated with routine endodontic procedure and sodium hypochlorite and using EDTA. So besides the two irrigants I talked about, the sodium hypochlorite and chlorhexidine gluconate, there are many other irrigants which have been tried the period of time, which are like using MTAD, tetracline, electromechanically activated solutions, ozone, photo-activated disinfection, herbal irrigants, lasers. There's so many things have been tried. See, the science means evolving over the years. People keep trying to find a better solution to the existing one. But so far, nothing else has come out which is as effective as sodium hypochlorite or chlorhexidine gluconate. The only hope is MTAD, which is a mixture of tetracycline, citric acid, and a detergent, which has shown little promising results. And this is how it looks like. Again, this is a product which has been invented by Tora Benajad, the inventor of MTA. But it is available in the American market, but is still not as popular as sodium hypochlorite is. This is how it is available. So this is the only one which is, as I said, shows promising result. So this is a picture just to show you that the red picture on your left side is how the pulp looks like in a tooth, how complex the tooth surface is, the pulp canal system is. And the green one shows that how you would like it to be treated. So the red is a pulp, green is an obturated canal. But does it really happen? You cannot achieve this because your endodontic materials, obturation material, instrumentation, they do not remove the whole pulp. They cannot penetrate into all these small canals and accessory canals at times. And what you see on the extreme right is a picture where what was originally the pulp system, the canal system, and what you can achieve by instrumentation. So the red part means that these are the pulp spaces or pulp tissue which has not been touched at all with the instrumentation. So how do you reach those pulp tissues? How do you reach out to these leftover pulp? So your best bet is to use irrigant. which only can penetrate into these areas where your instrument cannot go in. And to make your canals, these irrigants more effective, you can use some more mechanical means to reach there. What happened was that over the period of time when we were using these rotary instruments, as these instruments start becoming popular, the trend became to use instruments of greater taper. First, hand instruments are 2% taper. Then the trend was to use 4%, 6%, 8%. We have seen instruments which even do prepare up to 12%. So what happens is when you are using instrument with so much of flare and so much of dentine is being removed, and over that you remove, try to remove the debris by using sodium hypochlorite either at high concentration or at very excessively, we have found a lot of fractures happening and cracks happening within the dentine and leading to endodontic failures. So I'm just showing you some CBCTs of some patients. These are my own patients who have had endodontic treatment, and over the period of time, they have shown cracks within the tooth system. This is my own observation that in last few years, the COVID, of course, has added to this misery of cracks and all. A lot of patients post-COVID develop a lot of cracks, but that probably is because of the mechanical force they use, the stress the people are in right now. Bruxism is so common. But besides that, endodontic treatment, if properly done, and if the canal, if the tooth has been treated well and the patient comes back to you with some complaint and you see a periapical lesion, and we have got it investigated with CBCT, we have found that invariably there have been fractures or cracks within the tooth. And when I went through the literature, I found that one of the major cause was using instrument with great taper, removing excessive dentine, or removing, trying to remove the pulp tissue or the dentine, or using irrigation more frequently and in fact using higher concentration. So these are very common, these kind of cracks these days. So my recommendation is don't use instruments which have very high taper. There are a lot of instruments available today with lesser taper and very effective in removing the pulp tissue, and you just have to enlarge the canals to 4%, at maximum to 6%, not beyond that. Don't try to remove too much of dentine, that will undermine the tooths and can lead to cracks and fractures. When you are using irrigant to make it more effective, you want to use, you want to enhance the effect of the irrigant. How you use that is either you use any irrigant which has a lower pH, which is less harmful, number one. Number two, increase the temperature of the irrigant, like in case of sodium hypochlorite, or you add some surfactant to increase the wettability, or you agitate the irrigant so that it can go into the dentinal tubules where the microorganisms are housed. Of course, nanotechnology has also been used with very mixed results. So the most effective has been found that if we agitate the irrigant, it increases the effectiveness of that irrigant. And how you agitate the irrigant, either you do manual agitation or you use ultrasonics. What is manual agitation? That when you put the irrigant in the canal, when you irrigate it with the hand instrument, you can agitate that irrigant. That will help it go into the dentinal tubules to remove the microorganisms. Or otherwise, you can use ultrasonics to do the same, which is done more effectively. But before you do that, you must remember there's something called biofilm. Biofilm is that the bacteria, as we are talking so much about bacteria do not exist only like loose bacteria lying within the canal system or something which is sticking to the canal walls. Bacteria are always found in clusters, and they are in a sac. They are not lying loosely. They are in a polysaccharide sac. And when you do your instrumentation, you try to agitate, they do break down into small sacs. And unless until you are doing little aggressive agitation, those sacs do not break down into smaller clusters, and then only you are able to remove them. If you just irrigate them without agitation, they'll get dislodged from one wall and get attached to the other wall. So you have to break those polysaccharide clusters into smaller ones, and by agitation you do that. Manual agitation would not be able to break down into smaller clusters for them to be removed. If you use ultrasonic, it will break them to such an extent that it's easy for you to irrigate and remove them. So the biofilm has to be broken down, and for that we use endosonics. And the advantage of using endosonics is not only for the purpose of irrigation, they also help us finding calcified canals. There are some, these days we use endosonic. There are special ultrasonic instrument tips which are available to remove pulp stones or open the calcified canals. And then any separated instruments, if in the canal system, the ultrasonic helps us to remove those too. It, as I said, it increases the effect of the irrigants, and it is also used for condensation of kataparka for obturation. It's been used for placing the MTA and for doing root end obturation. Whenever we are doing apical surgery, we can use ultrasonic to make an excess, periapical excess, and place our restorative material in MTA. So this is a patient with 4 canals, MB1, MB2, and so this is post ultrasonic and obturation. So remember that irrigants must be brought into direct contact with the entire canal wall surface, but particularly in the apical portion, then only they become effective. And ultrasonic agitation does that. It takes the irrigant up till the apical 1/3 and into the dentinal tubules for that. So it vibrates at a precise amplitude, and it takes the irrigant into the canals and the dentinal tubules. It also increases the temperature of sodium hypochlorite to make it more effective. So that's how it kind of agitates the hypochlorite to make it more effective. And this principle is called acoustic streaming. And in this, there is no, the role of the file is just agitation. It is not used to do any canal preparation. So what is advocated is that you use ultrasonic for 1 minute in the canal system, and it helps clean the canals better. So these are some of the cases. This is a retreatment. So one question which is often asked is, can sodium hypochlorite and chlorhexidine gluconate be used together? Because one is very good bactericidal, the other is very good to dissolve the hard and soft tissues. They cannot be used together, because once they if they are used together, they form a byproduct which is considered to be cytotoxic. So it is not advocated that you use them together. So if you want to use both, in that case, first use one, then wash it out with this normal saline, and then use the other one, but not one after the other. So before I conclude today, the irrigant which we use today in endodontics, the first choice is to use sodium hypochlorite for any non-vital tooth, and where there's no open apices or perforations, where the irrigant is not likely to come in contact with the periapical tissues. And for open apices, perforations, pediatric patients, it is the irrigant of choice is to use chlorhexidine gluconate. Other thing is that you should use ultrasonic for agitation of sodium hypochlorite to make it more effective. And 17% EDTA for 1 minute is very effective in removing the smear layer. So I hope all of you will enjoy doing better endodontics in the coming years with new materials and new concepts coming in. As I mentioned, today imagining doing endodontics without any kind of magnification is not rather unbelievable today. So all of you have to start using magnification in case you are not using it. If not microscope, at least some loops, etc. to start with. And we have to kind of start moving to doing better dentistry than what we were doing. Use rubber dam, and always make sure that the patient's safety is of prime importance. Do not try to use any irrigant at a lot of pressure, or because there can be a lot of mishaps, and these are all avoidable. Before I close, I will like to share with you that IDA is hosting an International Digital Dental Congress in Mumbai in June, and this is going to cover even digital endodontics. The video didn't play. इसमें वीडियो चलेगा क्या? Can I play the video? No. Oh, you can.
इसमें आएगा ना वीडियो स्नैपचैट
1 मिनट का है, वीडियो ज़्यादा नहीं है.
इसे वो आएगा ना आप अगर पेन ड्राइव दे सो मैं वहाँ चलवा दूँ
पेन ड्राइव लगी हुई है इसमें.
नहीं वो वाले लैपटॉप तो फिर वहाँ से चल पड़ेगा ना वीडियो तो फिर यहाँ से पीपीटी
तो यहाँ पे तो ख़त्म हो गई पीपीटी.
खत्म हो गया तो दिस इज लास्ट स्लाइड
हाँ.
सर
I'm just showing you a small video of the Digital Dentistry Congress. This is going to be hosted with the European Society, Digital Dental Society, being held in Geo Center in Mumbai, and it's covering all aspects of digital dentistry, including endodontics. And Geo Center is one of the best, rather I would say the best convention center in the country today. If you people have been seeing the media in the recent times, new Nita Ambani Center for Art and Culture has been set up there. This conference is happening in the same venue where this center is opened. The venue has a seating capacity of 3,000 delegates, state-of-the-art audiovisual facilities. We have 24 international speakers and close to 30 national speakers participating in this. And this is going to be the game changer for dentistry in India, because never ever such a big digital dental conference has ever been organized in India. I'm just going to share a small video to show you how the facilities in Geo Center are, if it can play. Sound है इसमें? Sound नहीं है? वीडियो तो चल रहा है.
वीडियो की साउंड का बेटा.
This is the Geo Center. These are the international speakers who are coming in. So all of you are invited in case you are interested in going into the future of dentistry, which is digital dentistry. Please come and attend this conference. I'm sure Dr. Himanshu and the team from Rishikesh, Seema Dental College is going to be part of it. They cannot be left behind in such an important event. Thank you so much.
Thank you, Dr. Rajiv Chuk sir. I sincerely thanks you to deliver first N.K. Agarwal oration in Dentocon. And you know I am a prosthodontist and sir was my mentor, teacher, sab kuch. So this is my dream to start a oration in his name, and with the blessing of God we have done it, because what I think कि माता पिता और गुरु का कभी आप ऋण उतार नहीं सकते। तो अगर इन छोटे छोटे कार्यों से हम अपने गुरु को, अपने माता पिताओं को कोई सम्मान प्रदान कर सकते हैं तो हमारे लिए बड़ा सौभाग्य का अवसर है। तो डॉक्टर N.K. अग्रवाल ओरेशन के लिए मैं डॉक्टर राजीव चुक सर का एक बार पुनः धन्यवाद देता हूं आप सबकी तरफ से। थैंक यू। नाउ ऑन बिहाफ ऑफ Dentocon organizing committee, I would like to felicitate Dr. Chuk sir, and I request both chairpersons to do the honors.
I request Dr. Himanshu Aaron sir to please felicitate the guest chairpersons also, Dr. Jyotsna and Dr. Manoj Mittal sir. A huge round of applause, please. Thank you very much, sir. Now we all need a break, I think, for some time. So just 5-10 minutes, let's play. Let's have some questions to tickle our brains until the next speaker is
Before Dr. Avantika will ask a question, I will like to tell you there are surprise gifts. Those who are giving right answers, they will get the gifts during valedictory function. So we remain here and scribble your mind and try to earn maximum gifts. Thank you.
Ready? पूछें? चलो, बहुत आसान है. Which fiber is responsible for the conduction of pain impulse? Please raise your hands. थोड़े हाथ और बढ़ाइए. इधर वाले ज़्यादा जवाब दे रहे हैं इधर से, क्या बात है? चलो. And the answer is? Yes, that is the right answer. A delta and C fibers. Applause, please. Our own PG student. Name?
Dr. Vaishnavi.
Thank you. Now, next. What is the most suitable material for making impression of a partial dentate patient? And Dr. Manas is going to answer us. Yes, that is the right answer. Elastomers. Going over to the next speaker, the next presentation is by Dr. Rumpa Vig ma'am. And the chairperson for that session, the first chairperson is Dr. Vikas Ramola, ex-HOD, Oral Surgery, Department UDMRI, and founder president AAOMSI. And the second chairperson is Dr. Ketki Kaleli ma'am, managing director, Neuron Institute of Applied Research. Ma'am is an oral pathologist and director, Dentopath Oral Pathology Lab. I request Dr. Vikas Ramola sir to please come on stage and introduce our guest, keynote speaker, ma'am, Dr. Rumpa Vig ma'am.
Hello. Our next speaker is Dr. Rumpa Vig, a renowned personality in the field of aesthetic and cosmetic dentistry. She done her BDS from GDC Indore, PCAD, New York University, USA, clinical education consultant, Palpident, USA, key opinion leader for Philips, Zoom, OSC South and Southeast Asia, Cosmodent, GC Money at Dent, guest faculty, New York University and Hong Kong University, ex-president in 2021 in Indian Academy of Aesthetic and Cosmetic Dentistry, fellow, Bangladesh Academy of Dentistry International, as the international key opinion leader for some of the leading international companies. Dr. Rumpa Vig delivers keynote presentation and instructs workshop on topic in restorative and aesthetic dentistry around the world. Over 884 lectures, presentation, workshops, and counting. Some of the countries she keeps being invited to multiple times for lectures: the United States, Germany, Hong Kong, Malaysia, Spain, Singapore, Thailand, Philippines, South Korea, Vietnam, Myanmar, UAE, Cambodia, Bangladesh, Sri Lanka, and Indonesia. And India, invited speaker for professional bodies and institutions from all across the country. She maintains 2 private practices in Bhopal and focuses mainly on aesthetic restorative, adhesive, and minimally invasive macroscopic dentistry. She is a graduate in Sangeet Visharat, Gandharva University in North Indian classical vocal music. So it's over to Dr. Rumpa Vig.
Thank you, Ramola sir, and awesome meeting you after a few years here. So, Himanshu sir, with your kind permission and Ramola sir's kind permission, just in this Devbhumi Seema Dental. So, with that, and it's really a beautiful place to be in, and restorations using my preferred aesthetics. So, if I see aesthetic dentistry, according to me, it can be divided into non-invasive, minimally invasive, and invasive. Yeah? And if we see non-invasive, what is when you do nothing to the teeth and yet you glamorize the smile? Teeth whitening. Yeah? You don't touch, you don't prep the tooth, you don't do anything, but just a 10 or 15 minute session brings back that beautiful color of the original tooth, which is the enamel. Enamel is white, right? And do you think when you have a jaundiced eye, when the eye turns yellow? No. Right? No. But why do we neglect a yellow teeth? Think about it, we can talk about it to the patients that the healthy tooth is white. So teeth whitening is a fantastic non-invasive option to glamorize smile in the shortest possible time. And then we come to composites. As I said, I had a fantastic session yesterday with most of you here. Hi there. And see, this is kind of the bread and butter dentistry. We all do restorations, posterior, anteriors, semi-anteriors, you know, all kinds. We are just doing that. So yeah, composites is there. And it's a very versatile material. Very versatile material. You use it, etch, bond, place it, sculpt it, match the shade, and small nip and tuck dentistry, and you can change the smile completely. And here, yes, you can also get back the young look of an aged patient. I won't say aged because today the number does not matter. Not at all. It is the mental state, right? So just a little tuck here. Oh, it's working. Yeah. Just a little tuck here, and it is there. We can do. This is where I practice in Bhopal. That's my husband, furiously looking for more canals and more canals. He does the endo, and I do the resto. So there's always a tug of war going on between the two of us, you know. I always tell him, he says, endodontics is the heart of the tooth. I said, yes, it is. But what we do as resto is the pericardium. If I don't give a good pericardium, the thing should not reach to the heart. So it's like a good endo, good resto. But of course, both resto and endo are our bread and butter dentistry, correct? And that is the view which the patient can see. And there's a lot of peacocks, small deers. So that is the view my patients get there. So basically, see here, I'm kind of talking to you about doing a smile makeover with the absolute basics. What do we need? We need a good etch, yeah, good bond, good light curing unit, and of course, a good restorative. So here, if we see, there's a huge load of gang of universal bonding agents. They are all in the market. New ones are coming in, and each having their own nuances, yeah? Technically, these are just some commercial names available in the trade market today, but there are much more. And they bond to, of course, enamel, dentine, they have to do that, right? And metal, composite, zirconia, ceramic, they should be able to work good in dry field, they should be able to work good in wet field, and so much and so on. And of course, with the advent of universal bonding agents, the challenges has been solved for the, do you do a total etch? Do you do a selective etch? Or do you go for self-etch? So that problem has finally been solved. Basically, depending on the case, selective etch is the preferred genre to be used here. And once that is done, I'm sorry, this moved back. Just that's done. And here, very proud to introduce to you a new 7th generation selective etch bond, the magic bond from Money called the Money Bond. How is it different? First of all, clinical usage. Most of you had worked with me yesterday, right? There was no pooling. Pooling doesn't happen. You just take it in the brush, apply it all around the prepared surface, and it just stays where it is supposed to stay. Beautiful, thin layer, and it is made for self-etching also because it contains an acidic monomer which has a pH just above 2, which is around 2.4, 2.5. So that makes it adherent to self-etch properties also. So this is a 7th generation bond for one-step bonding. So again, your clinical chairside time saves out. The best part for me as a clinician is that it's got a good shelf life of 2 years, you know, and then we move on to a good light cure unit. Light cure unit plays a very important role. Whichever way we are doing the restorations, may be direct, indirect, cementing, with dual cure, anything. And light cure, if we see, has effect. This is actually blocking what I'm going to show, but this is not a rocket science. So when we place the light cure gun from the occlusal surface, the max polymerization, 65% around, is happening on the occlusal surface. And as we go deeper, the percentage of conversion of the bonds, the double bonds, become less. So at the bottommost layer, it should be around 15%. So what we normally do is occlusal, yes, once you are done with the 20 seconds, according to the composite that you are placing, kisi ka 20 seconds hai, kisi ka 40 seconds hai, check the time, and then shoot one from the labial, shoot one from the lingual. That kind of helps. And most important, on the eyes. These days, whole time we are just with our mobile, which has got a blue screen, our iPads, our computer screens, they are all blue. And on the eye, you know, the blue light hazard, it can induce retinal injury in this wavelength of 400 to 450 nanometers. Especially in persons above 40, I'm a proud one. So what happens here, our antioxidants are reducing with time. So this light effect is extremely important for us because it gives the age-related macular degeneration. So please wear those orange goggles to the patient for you, and of course that circle around the light for protection. Himanshu sir, yaad hai aapko? Long time back, Ramola sir, Domal sir baithe hain. That was such a fantastic conference with you all, and really, really a proud moment because had a fantastic time with Himanshu sir. And that's where I discovered, apart from being a fabulous prosthodontist, he has an amazing control on Urdu Shairi. He's awesome at it, you know, so that's where I discovered. Sir, is baar sunna reh gaya, but next time bilkul aapka sunna hai. So now if we come to restoring with composites, it's like affected by each and every step. Like isolation, important. Prep form, how are you doing the enamel? How are you prepping the dentine? That's important. Selective etch works better. And then drying without over drying. If we over dry, what's going to happen? The collagen in the dentine is going to collapse, which may, not may, it does weaken the bond. And please read the IFU. Some bonds need to be scrubbed. Some bonds need to be painted on. They all have different nuances, so read the IFU. मैं पहले नहीं पढ़ती थी. अब मैं पूरा पहले पढ़ती हूँ. You know what is the exact method to apply those. And then angle of curing light. Curing time, check the light cure unit. As I mentioned just right now, it's very, very important. And matrix and wedges, incremental fillings to avoid the C-factor issues. And then, when we do a class 2, normally, we go in for a first layer as a flowable composite. Of course, after etch and bond. But all flowables are not same. All flowables are not supposed to be placed on the, as a base. You have to check which material you are using. So here, very proud moment for me because I am a guest faculty at Hong Kong University. That's one of the batches. This was before COVID. And they say that they have the #1 dental faculty in the world. I disagree. I disagree. We have the best faculty sitting right here, and I'm so proud to be presenting in front of them. Absolutely. So, introducing to you a new range of composites. We have been playing with composites since years, right? So, new range, of course, bond we just discussed. We have a flowable viscous. We have bulk. We have nano. We have micro. And this whole range makes restorations extremely fantastic to work with. So that's a day in clinic working on patients. And what we are doing, this is a case that came to me. You can check the date. It is 26/08/2022. New person who just passed out of People's Dental College. It's like me, it can be you. When I was fresh pass out, I could have done the same thing. He sent this case to me कि मैम मैंने ये केस किया और करने के बाद पेशेंट को बहुत गर्म ठंडा पानी सब लग रहा है, आप प्लीज देख लो. ओके फाइन. आई सेड क्या यूज किया था, मतलब व्हाट डिड यू यूज इट विथ? ही सेड मैंने सेंटियन डाला. सेंटियन इज अ गुड मटेरियल, ऑल गुड, बट इफ यू कैन सी हियर the adaptation to the tooth has not been proper. Yeah? There's a lag in the occlusal surface, there's a lag in the mesial surface and the distal, and of course that gingival box, which is of prime importance for doing any good class 2 restoration. So that was lacking. So my question to you is the composite which you're using in your daily OPD here, or if you're attached to some practice, or if you're doing your own practice, does it adapt easily to the nooks and crannies of the prep that you have done? Yeah? So here, just showing you a case, tooth number 43, post-endo. Of course, my husband's department se endo hoke mere paas aaya. That's the scene. Yeah, so here, remove the excess caries. You can see it's all dark. Used straight one shot of money bulk, so that is money bond I'm using. And here, money bulk has been placed. I'm placing it, and you can see this is actually blocking the photo a little, but you can see what's happening, right? I'm placing it directly, squeezing it down, and removing the excess with a silicone tip, which I love to use in my practice, and post-finishing, polishing everything, this is what I can get. This did not take me more than 8 to 8.5 minutes because it's bulk, ease of chair side, and it helped me great deal. One more case. This is the second premolar, and here, if I can talk to you, we need to see what's happening. Like Chuk sir just told, today is the age of loops and magnification. Without that, if you don't see, how can you work? Right? So if you can't see or detect, what will we do? A good idea is to use a caries detector. Any brand, doesn't matter. Just pick up and use. Personally for me, I use Snoop. And what it does is 10 seconds application, this material bonds to the denatured collagen. Okay? And in the outer infected dentine, but not present in the inner affected dentine. So that helps me where my margins or the walls will be. So this distinguishes, and we just need to remove the outer infected dentine. Going back to that case, yeah, I apply the bond, sectional matrix, polymerize, use this bulk again, completely put it in, squeeze, there, excess, remove the sectional matrix, polymerize, once again, finish polish, and this is it. Again, less chair side time for me. Yeah? One more case, that's distal caries, prepped, use this bulk, and done. Finished, polished, and done. Extremely simple. This is tooth number 34. Right? And here I prefer warming composites. I have been using it for 2 years now, and they really help me in my clinical outcome. So pre-warming the composites has a lot of good points, which is not my scope to discuss here, but sometime later I will tell you about all the current trends that's happening in the resto. That's about a 3 hours lecture of mine, including 1.5 hours of why do restorations fail? Very important topic for all of us. So here, applying the bond, building it up, and there it is. This I have used Flow V. Flow V is flowable viscous. And it's got 77% filler particle size, the weight, and so it bears the load. So this is all in all, standalone that. Tooth 26 here, and this I didn't use an etchant. I used the self-etch property of money bond and painted it on, light cured, and standalone I used Flow V to complete the restoration. There, squeezing it in, checked the balance, occlusion, with articulating paper, and there's the restoration. So as Ramola sir was very kindly introducing me, happened to be a guest faculty at New York University, and my next course is happening in September. So I will keep sir posted. If anybody wants to join in, I will let you know how and why. And that's a nice, proud feeling for me to represent India in that level of the world in the US. So here, patient came in from the gate pe, welcoming the patient, okay. Baitha hai, so patient comes in, she's Nainika, and Nainika, if you can see, there's a peahen walking right there. So what happens is patient is very relaxed. With that kind of green view, everything nice, extremely relaxed patient. So Nainika had this problem, she's 53 years, and if you see, one tooth is darkened, and she has a straight smile line, completely straight, which she says, of course I also know, it makes her look elderly than what her age is. All right. Started working on her, prepped the teeth, etched it, and first layer I used is the Flowy. Painted it on. I use a brush to paint on the Flowy, and then I used Money Nano, the Nano from Money, and just made it into a nice shapely blob, placed it, adapted it, and there it is. So with that, doing the 2 central incisors from straight smile line, I could give her a curved smile line. Easy to do composite restoration with immediate change in smile, and that works wonders for the self-confidence of this girl. Another case, patient came to me with a fractured, very old veneer, a composite veneer done, fractured upper left canine. Yes, you can see the fracture, and removed the old composite. That's it. First layer, Money Flowy, and then I built it up with Money Micro. So that was the thing. Money Micro again has got excellent strength to bear the load there. And to learn more about balancing, I am into occlusence by Bausch. So I was trained for this, and what it does is it gives me not just the static contact. It allows me to see the contact in 2D and 3D from the first contact to the pathway when it is reaching the maximum intercuspation. So that helps, just a little tool. So this is how that works. You need an iPad and a Wi-Fi to connect with it, and simple thing, just some adjuncts to help us. And as Chuk sir is right now going ahead with the digital dentistry in June, please gear up. It's going to be something worth, totally worth. Yeah. So, like when we do direct veneer, we have options of multi-layering, 2-step layering, or single shade layering. Okay. So about single shade, we say that shape is the new shade. If you give a shape properly, shade is not that important. So this is a case with the patient, and this patient is not koi aisa vaisa patient. She is my senior. I have been taught by her in Indore. She chooses me to get the work done. I mean, I was a little nervous, So she is not happy with the existing veneers, wants her teeth looking whiter and longer. All right. So what I did, instead of going the direct option, I chose the semi-direct option. She's from Indore. She's not in Bhopal. I practice in Bhopal. So I prepped, first pre-impression, then I prepped, I took an impression, and then UL impressions taken, poured, mounted on articulator, 10 veneers to be done. I used Money Nano and Flowy, and these were the shades I used, because she wanted whiter. So this was my shades, B1 for 11, 12, 13, 21, 22, 23, and for 14, 15, 24, 25, I used A2 and A1. All 10 veneers done. Once I prepped the 10 veneers, I threw it in for heat under pressure for 20 minutes and ready. So when she came to me from Indore, I made her sit on the chair. My armamentarium was just an etchant, a bond, and the same flow to lute it. No cement, okay? Here she is, and as I said, she's very happy. But once I saw the close-up, I was not happy. Her lateral is looking smaller. I didn't like it. So I said, Di, आप एक काम करो, आप मॉल घूम के आओ, आप 1.5 घंटे बाद वापस आना. So I changed this, and this is shorter. So this is what I could give her. She has gone back to Indore, but I keep calling her every 10-15 days. It's just 3 hours drive from Bhopal and superb roads. Sir, aap aa rahe ho. Hai na? Aap aa rahe ho. So that is that. And this was done in the semi-direct way. And if I tell you, just before I flew out, 19th I flew out to reach this precious Dev Bhumi of mine. 18th case comes. He's Manoj Bawa, a dear party friend of mine. He comes and says, Rumpa, ye acha nahi dikh raha, bahut purana ho gaya, isko change kar. This veneer on the lateral, all right? Okay? Money burrs are again a good tool to use. You must be using burrs because the restorative range is a new entrant for them. And there I hooked on to this TR13SC burr. I removed the old one. It was endodontically treated, and this is what it looked like. All right? Prepped, I used the retraction cord. Once I use the retraction cord, then here, etched, and then of course placing the bond. I dip it in the brush. I normally use a brush to apply the bond. And here, at the khidki, a little dove is watching what's happening in my clinic. My area is full of birds and peacocks and deers and everything, right? So this is how I'm applying the bond. And with the brush, compared to the micro brush, you are more easily entering into the contours everywhere, and it gives me an even balance, you know, when I'm placing the bond. So once done, of course, air thin, and then I use a light cure. So that's post bond. Adhesive layer is done. Here, what I used, as I said, etchant, I used an etch-right. Money bond, I just showed you. Now, for this area, I used Flow V A1 shade to cover that defect, which is very starkly showing, you know. And then the outer area, I used Bulk Fill A2. So that I covered. And then, I don't know, I've gotten the habit of layering the full thing with Flow V. It works wonderful. I just love that material. And Flow V A2 shade, I used with a thin paintbrush, covering it all, and then I topped it up with nano. Okay, so the final enamel layer was done with nano. So this is not yet shaped and contoured, so you can see it looking a little wider. And yes, the guests again, Manoj also saw, Nainika also saw, so they are just there, and in here is a little bulbul. So, fun. So now I start finishing polishing. You can use whatever system you like, whatever your hands are comfortable with. Me personally, I prefer top finisher system from Cosmedent. I use plenty of small stuff from Shofu, from Dentsply, all in all. And recently at IDS, I picked up Diacomp. They gave me a short training. Why? I was excited about it because they said you don't need a polishing paste. I said, okay, let me try this out. So this is the rough and the final. So I'm just using the rough. That's the Diacom from Eve, just to show you what's happening the world around. Not asking you to pick up, not asking you to do anything. So that's what it is. And here. Now, after completing, I can see that there's a extra material here. There's an overhang. And it's kind of looking, this is quite nice and cervical, the central, but this is kind of a wide neck, cervically wide neck. Why? Because I showed Manoj with a mirror. I said, इसको करूँगी तो तेरा ये cervical embrasure बहुत deep हो जाएगा, तेरा बहुत खाना फंसेगा, उसे छोड़ दे. As such, he didn't have a complete cervical showing. That means his smile line is kind of subgingival. It's not at gingiva, it's not supragingiva, it is subgingiva, so which helped. Otherwise, I would have contoured. So yes, I removed that overhang, and there it is, all done. And so from here to here, just the day before I came, so this is what we could give. And as I said, good restoration, good bond, good etch, they really give you a happy space in the clinic. And more so, if you find that technology is so, it's advanced so much, you know. And in June, as I said, Chuk sir is doing the digital dentistry. Digital is the time now. So with that, if we have some nice, happy, quick restorations that give me predictable results, I can balance the occlusion beautifully so that my restorations last longer. And so with that, we have the bond, the flowy, the bulk, the nano, the micro. Pick your choice and just go ahead and start working. It is 1 or 2, 3 or 4 cases, and you know, you kind of get the hang of it. It's not difficult. None of us were born with these kind of skills in our mother's womb. We came out, and as I said, हमारे time में most of us didn't even want to be dentists. Yeah? हम तो आ गए, ठीक है, आ गए, but अब आए हैं तो अच्छा करेंगे, बिल्कुल करके जाएंगे. So with that, those are the restorations, and I'm extremely, extremely thankful to Dr. Amit Gupta, S.S. Jha sir, he was there in the morning, Himanshu sir, always, and Jyotsna, Anil Dhingra sir, and all the complete COC of this fantastic Dentocon, and of course, Team Money. Thank you so much for your unconditional support, always, really. Big, big thanks. So with that, big thank you. And before I end, just sir ke liye 4 lines. It's Rishikesh, it's the where Ganga aati hain, avtarit hoti hain. So just 2 lines for that. Ek need hai Ganga ji, ek naam hai ek Ram, ek Chandra hai ek Suraj, nirbal ke Balram. Thank you, sir. Thank you so very much. Thank you.
Thank you very much, ma'am, for the enlightening, dynamic, and melodious presentation. Thank you, ma'am. I would like to request the chairpersons, Dr. Vikas Ramola sir, Dr. Ketki Kelele ma'am, to please come on stage and felicitate Dr. Rumpa Vig ma'am. I would also like to request Dr. Himanshu Aaron sir to please come on stage and felicitate our chairpersons, and Dr. Chuk sir, Dr. Rajiv Chuk sir. Continuing with the next session, the speaker of the session is Dr. Prashant Bhasin, and the chairpersons are Dr. Samit Jain and Dr. Narayan Prasad, sir. I request both the chairpersons to please come on stage.
A very good afternoon to everyone. Thank you, Dr. Akriti. Thank you, Aaron sir, Chuk sir, Dr. Amit Agrawal, Dr. Jyotsna for all the organizer for inviting. Our next speaker is Dr. Prashant Bhasin. And Dr. Prashant Bhasin is the Vice President, International Association of Dental Research. He is a postgraduate from SDM College of Dental Science, Dharwad. He has a wonderful 17 years of experience in academics and clinical experience. Dr. Bhasin is currently head of the Department of Conservative and Endodontics in Sudarastogi Dental College, Faridabad, Haryana. He is a faculty at Alit Academy at Dubai for the Professional Diploma in Endodontics. Dr. Bhasin has been awarded as the Best Dentist of the Year 2015, along with Professional Excellence since 2015. He is a proud recipient award of Best Microendodontist of Decade in 2021. He also has been awarded with the Most Proactive Academician of the Year 2020-21. Dr. Prashant holds an international certifications in engine drive endodontics by Essential Dental Seminars at Hands-On Dental Education Center, New Jersey. And Dr. Bhasin's Dental Academy is the first authorized training center of microdentistry in Delhi with Karl Zeiss, Germany. He is currently president of Indian Dental Association, Northwest Delhi 2023, and is the first honorary member of India for excellence in the Endodontics Association group. First international key physicians for Karl Zeiss from India in the field of magnifications. There's a long list for the Dr. Prashant Bhasin. In short, I would say he's an encyclopedia of microdentistry in endodontics. Welcome, sir. Thank you.
Hello. It was quite light. Okay. So, thank you so much, Dr. Samit. And first of all, thanks to Dentocon. And thanks to Himanshu sir, Rajiv sir. Himanshu sir was my teacher at one point of time when I started my career in dentistry, way back 1996, my first teacher in the dental school. And it's an honor for me to be here among the young brigade, what we always talk about, right? Because what we look at as an endodontist, okay, before we go ahead with it, the first thing is, how many of you are doing an endodontic procedure here? That's very important. Rest are not doing? Okay. So, but the first thing what comes to you when you joined dentistry was what? Root canal treatment? Okay, you have got any time your root canal done? Any of you? There is nobody who got a root canal done till now. So you are the lucky one. So maybe we get the chance to do sometime in future. But all said and done, as we move forward, our mentor, Dr. Rajiv sir, has taken a fantastic lecture in the morning. And I think that was the first lecture which was very much required to understand what exactly endodontics is all about, right? So he has shared his views and experiences in the last so many years that how the irrigation protocols and the newer methods are changing the entire perspective. So, but with the time evolving, we have to make sure that how the endodontic procedure can be made in a more better form, and that is what the future is all about. So I'll be sharing my views for next 45 minutes on the different procedures, how you can make your endodontic procedures much more predictable, safe, and efficient, right? So, did he remove that, I guess? Did, no, I put my, हाँ इसमें लगा हुआ है, ये रहा, दोबारा लगा, निकाल के लगे. Yeah, I guess.
साउंड भी चल नहीं है ना?
क्या करना? Let's wait for a second. नहीं अभी नहीं होगा. Let's wait. No, it's happening now. Scream. Okay, thank you. Well, technical glitches is a part of it, not to worry. Right. So, if we talk about the endodontic procedures in toto, the first thing is what, as a clinician or as a first beginner, what you get is a what? Is a fear, right? If you see this slide, you have fear, you have anxiety. If you talk about the endodontic procedures in toto, the first thing is what, as a clinician or as a first beginner, what you get is a what? Is a fear, right? If you see this slide, you have fear, you have anxiety, you have disturbances, you have many things that actually stop you to do an endodontic procedure, right? But if you see on the right side, you have a big vision to see. That means you need to open up your horizons. You need to think futuristic approach that how you can make your endodontic procedures more predictable. And definitely, yes, with the addition of world of magnification in the field of endodontics, they have become much more predictable and much more achievable. So, this is the most common question which I always put in my slide, and that is what, that how do I choose a rotary system in my practice? There are thousands of systems with us, right? You go into the market, there are thousands of systems which are available. Some says this, some says that, right? But there's always a big question which is unanswered. So every doctor or every dentist, he has certain questions in his mind that how exactly he can choose a system, right? So these are the few things that depends on every clinician's perspective. Somebody looks for a good efficiency, that I want a system which is more efficient. Some talks about the science, which is ductility. Some say that it has to be very fast, so that means it should be very sharp, that we are able to prepare the root canals faster. Some looks for another science with scientific technologies like a cross section. And somebody looks for the flexibility, but at the end, everybody looks for one thing, which is the cost. Because if it is not coming on your pocket, even if you talk anything which is big, you will not like to use it. But at the end of the day, what we need to understand that rotary endodontics comes with a lot of problems. So today I am here with all of you to give you a solution, what the rotary endodontics generally look for as a clinician, as a beginner, because the fear of the beginner and or even a seasoned clinician is what? Number one is a fracture. Most common fear of any endodontist or any dentist who is working in the root canal procedures is the fear of fracture, right? So there is a solution to it. But to do that solution, we need to know about the canals in toto. That is very important, because in endodontics, if we talk about, there are a lot of classifications which are given in the books. But I have made my own classification to make it much more simpler. So we say you see generally three types of canals. So you have a loose canal, that is like a central incisor, lateral, or a canine, right? You have a tight, mild with curvature, and you have a really tight with the severe curvature. So there is a protocol which I have followed and which I have formed so that I can make these canals much more easy to work with much more predictable results and much more faster that you can do it. Okay? So to do that, if you have a loose canal, when you start with the endodontic procedure, you need to understand the width of the canal to choose the instrument, and then followed by the rotary file which you have to use. Okay? And if you have with the curved canals, then you need to understand the value of the file which you need to inculcate. For example, if you see a curvature with a calcification, for example, right? So most of the time you see that, so in such cases you can use a file which is known as definder. Something to bypass the calcification, and then you go on to your rotary systems. And if you have a really tight or a severely curved canal, then in such cases what you must have felt that you have used a 10-number file which is easy to go, but when you go to a 15-number file, it's a lot of problems you face, right? So in such cases, the solution is a 12-number medium file, so that you can actually go to the apical third, prepare it well so that the irrigation can reach to that area, and that's very important, okay? And then you follow the rotary protocols. So what is the revolution what we have today? And the revolution is what we say is the 3-file system what we have, and that is known as ZISI. The meaning of the word ZISI is at your will. That means you can use this system as per your convenience, depending upon the canal. Not depending upon the canal, if you ask me, depending upon your convenience. Because eventually we are the clinicians who have to work inside the root canal. And file is just an instrument, right? So we should have something flexible in our hands, which we can use with our will, and we can work inside the root canals much more efficiently. So, but the question comes in, sir, there are 100 systems. Why should I really trust in a recently launched system? Isn't it? There are 100 systems in the market. So if I sit on your side, so I have few questions which come in my mind when we talk about any new system which is there. The first question which comes is, what is the instrument fracture rate? Isn't it? ये नहीं पूछोगे जाओगे जब फाइल लेते हो कितने किस कर सकते हैं? I think that is the first question you ask before the cost, right? Second comes in, does it outperforms the shaping ability of the system what I am using? How it is better than what you are using, right? Number 3, is the new system can be used in difficult cases with ease? That is another very important thing. Number 4, does the new system has a really technological innovation that it can really help me to work in those areas? Number 5, that it helps me to have the properties which makes it easy to work. And last but not the least, it should be simple to understand. Because something which is more complicated, you cannot use into the root canal. Because if you cannot learn that system, you cannot apply it clinically. Okay? So with ZISI, all these things are taken care. And definitely, you talk about any new systems, you need to do some scientific research. So there are many research which has been done by the team to know about its flexibility, cutting efficiency, its canal centering ability. So there are certain research papers which have been already published that you can see, which talks about the various cross sections of the file. So I'm not going in detail. So I will move directly on to the feature in the file which is more important. So I have final year students with me here. BDS final year? Perfect. So you must have read about a radial land. Isn't it? Radial land in endodontics. You read or not? Rake angle? No? But you ever saw a radial land? Only in the book like this. Right? Don't you think so? Even when I was a BDS student, I used to remember only 2 words, radial land and rake angle. After that, I don't know about endodontics, what it was there. In my final year. So I'm sitting with you on this side. So we need to understand that, is this radial land what we used to read? Is it there in the file, which helps you to work better and easily? Because radial land is what? Is a safety zone, which is given in a file. So if you see here, the ZISI has this radial land. So what does it helps you? It helps you to actually keep the file more centered in the canal, number 1. And also, it reduces the crack propagation. That's very important. So that means if you're working in a very curved canal, so then what can happen? File will fracture. So if a file doesn't have a radial land, 100% it will fracture. However good system you use, right? Next, you have heard about rake angle, right? Now, Zizai has a negative rake angle, so definitely yes, when you have to use this system, you have to use in a scraping motion. That's how exactly it has to be applied. And it has a variable pitch that is very important for the root canal preparation. And it has an off-centered cutting edge so that it gives you a smooth cut feeling, and it also gives you an efficient cutting ability. Because what we look at altogether when we are working in endodontic procedure is the safety. If my files are safer, I can use them with ease. If my files are not safer, I need to think before I introduce into the root canal system. So coming to the after science, let's see some of the clinical cases that what we have done with this system, because anything can work in a normal canal. Single central incisor, if you have to work, anything can work. Let's see how it changes in a different canal perspective. So let me show you the premolar, the most notorious teeth to manage. If you ask me personally, the most complicated teeth in the mouth are the premolars, right? Because they show you all the different anatomies what you can think about. Now let me show you a case. Now if you see this case, a lower first premolar with 2 splits in the middle third. Now, a very difficult case to actually do. Somewhere down inside the root canal, you need to see. Somewhere at the middle third. We talk about coronals, but somewhere in the middle third you have a fracture, right? Oh, sorry, the split in the canal. So the best way is that first you should use the ultrasonic tips so that you can refine your access cavity nicely. Again, thanks to world of magnification, already the 2 mentors who have delivered the lecture before me, they have focused the value of loupes and microscopes. Because if you see well, then you can treat well. And if you see deeper, you can find what? The sea, the ocean. And endodontics is a big ocean. But to do that, you need to have good goggles when you go for a swimming. I think the pool is open, sir, down? No, not yet. The pool is open. So how many of you go for a swimming? How many of you go for a swim in the pool down there? You go for a swim? No. Nobody. So those who are going, you do wear those goggles, right? Why you wear it when you are going down in the depth? You want to have a better vision. And that's what the magnification gives you, right? So that's what we have done. And then we have located those canals with the help of our hand files first. And then we have used our Zizai, that is at our will, so that I can do my orifice shaping into those root canals with more, which is more conservative, minimally invasive, and safe. That is what I look at when I treat a case. So you do that orifice shaping nicely, and there you can appreciate the 2 orifices in the middle third. See, this was the area, and this what you can appreciate with the help of magnification. And that you can see at the higher value of your microscopes, that you can check that. And then once you have prepared with the orifice shaper, you do a rotary glider, that is 1304, that is Zizai. And then you can finish up your preparation with one file, that is 2504, and you are done. So you don't need many files to work on. Just 2 files and you can complete the whole endodontic procedure. And there you can see that. We have obturated those canals. Because of the screen, you cannot see. What about this case? Another case I show you. Management of pulp stones and calcifications. I think the first step when you go inside the root canal, which stops you to enter, is a big stone, right? So let's see how you can manage it. This is a lower 7, okay? Again, use of ultrasonics, that is a key. Because when you are using, because if you have to do a minimally invasive endodontics, then from birds you have to shift to ultrasonics. That is very important. So ultrasonic tips, diamond coated, that what we are using, so that we can trough around that area and we can release that pulp stone which is there. Now this tooth has 2 pulp stones, not 1, right? So we did that. The first one is out, and then the use of a DG16 Explorer, which is one of the key instruments in endodontics that what we use, right? And this helps you to remove the floor of that pulp stone nicely. And the beauty of magnification is you can differentiate between the color and texture of the roof and the floor. Roof should be completely removed, and floor should be always preserved. That is the key to endodontic procedure. And the major problem what we do as when we are treating such cases is we perforate that floor. So that if you use ultrasonic tips, will not be there. Or if you want to use a burr, if you want to use it, then you can use an M15EZ burr. That is one of the beautiful burrs that you can use, which can avoid the perforation of the floor. And this is what you can see. A completely calcified chamber, right? You feel like that. So we located those 4 canals that you can see with the help of our D-Finder files. And then I tried to prepare it. So I started with the Orify Shape. I thought I did a great job. I closed this and I asked the patient to go back. So next day the patient came back to me. Can you appreciate what has happened? Can you appreciate on the top? I broke an instrument. So this can happen to anyone. You can break an instrument anytime, right? So not to worry. Okay? You need to manage such cases if you can. Definitely, again, if you have some kind of magnification with you, maybe loops can be helpful in such kind of cases to do, and the role of ultrasonics. So we used the ultrasonic tape to trough around the broken instrument, and what you see, the white thing here, is actually a Teflon tape to block the canals. That is very important, because in my initial years of my magnification journey 10 years back, I shared with you, I was trying to retrieve an instrument. I troughed, instrument came out and went into the another canal. So patient will pay only once, not twice to remove the same instrument, right? So make sure you block rest of the canals and then you trough with the ultrasonic tips. Now, already we have troughed this area, right? And if you appreciate this radiograph, what you see, a big periapical lesion along with the calcified canal. So first mistake, what you can do is not to use a rotary file. Okay? Remember that. So in such cases, you should go to a file which helps you to work in a reciprocation motion. So a value of reciprocation and a rotary file should be understood. So these are the reciprocating files we can use. These are the SECO files which I use. If you see the motion, it is reciprocating into the handpiece. And then I did a glide path because the canals were which are calcified. So with the 10 number SECO files, we did that, followed by the 15 number SECO files. Lot of irrigation, activation, and internal warming is being done. That is a part of the root canal treatment. Now, once that is being done, then the role of my Zizai glider comes in, because I have created a glide path. So if you have to make your rotaries flow into the root canal system, you need to create a path. Then only they will going to follow it. And that's what we did. We created a glide path with the Zizai glider. Recommended speed is 300 RPMs and a torque 1. So make sure whenever you are using any rotary systems, you follow the manufacturer's instructions. There is a reason why they have given. So you need to do it at the same speed. You cannot increase or decrease it like that. Okay? And this is the Zizai glider, one of the key instruments that I use in my practice, especially to create a glide path. And then followed by my files, the rotary files which we use. And there you see after the preparation. All 4 canals well prepared, gutta percha in place. Now, as there was a periapical lesion, so the choice of my sealer is changing now. Earlier we used to use zinc oxide eugenol sealer or the resin sealers, but now the world is shifting to the bioceramic sealers. Especially when you have those infected cases, it gives you fantastic healing. And that's what we did. And one of the best advantages of sealer is that it has an easy placement. Those who are doing a post-graduation, you are mixing the sealer every day. Powder, liquid, lete ho, mix karte ho. Either it is too loose or it is too thick. And then you add a little more liquid to make it loose, or you add a little more powder to make it thick. Do you think so much time you will going to spend later? So the choice of sealer changes from there. So we go from hand mixing to a direct delivery. It becomes easier. And this is how you do it. So this is the bioceramic sealer which I use. And just keep a watch here. When you have a confluence in the canals, you can see the good flow of sealer coming out from the other canal. And that is the key. That leads to a 3-dimensional sealing of the root canal system. Because root canal system is not only about just placing the gutta percha. You need to seal the root canal's walls 3-dimensionally. And that has been done. And then we have put the master cone. And finally, we have obturated the canals with the warm vertical condensation. And this you can see with Zizai. How beautifully the anatomy of the canal is well maintained at a two different angulations of your RVGs, right? So any system what you use which is difficult, it should be able to maintain the canal anatomy. That is very important. What about this case? Endodontic management of a upper second premolar with 3 roots. You get such cases in India. It's not on the international forum you get all such cases, if you try to look into that better. So if you see this, this is an upper premolar with 3 roots. Again, use of ultrasonics, preparation with ultrasonics, and this is what is desired. If you see the file, as I told you, you read about a radial land in a book. And what is a radial land? If you appreciate here, after every 3 flutes, you have a flat end. After 3, there is a flat end. After 3 flute, there is a flat end. And that is the radial land. Okay? So the incorporation of this feature into the file helps in what? Safety. That means you can use in any type of canals with ease. That is what exactly it is more important. You have no stress to take. It is a stress-free endodontic procedure. That's for sure, right? And another important feature, you can pre-bend it. I have turned this file because they are heat treated, and I can go and prepare my canals very easily. Because what you need is a flexibility along with that, along with the cutting efficiency, and that's what it helps you. So you can prepare it well, easily, and then you can restore these teeth back to function and aesthetics. What about this case? Difficult cases what we have done with the new systems design. Okay, 6 canals in a lower first molar. Again, if you see, this is a lower first molar, 6 canals, 3 mesial and 3 distal. Located nicely. There you can see that. And then use of the Zizai glider to create a glide path. And then followed by just one file, 2504. Because we don't want to cut lot of dentine now. Because earlier stages, we started with the 2% taper, went up to 10%. Now, if you ask me, if you follow the protocols of irrigation, as suggested by sir, with lot of ultrasonic activation, you need to prepare just 2504 in such kind of cases. And that's what we did. This is the 2504 directly after 1304. You can just go with one file and you can finish up the whole root canal. Right? And then we have placed the gutta parcha. All canals are prepared to 2504. And then placement of the bioceramic sealers so that we can do a 3-dimensional obturation of the root canal system. That is on the mesial side, and the distal side, what you can see, the flow, how beautifully it flows with the good preparation with the Zizai. And this again you can see the confluence. When you prepare with a good system, the flow of the material is always better because you have created a nice canal anatomy which helps the material to flow easily into those root canals. And then finally we have obturated with the bioceramic sealers, and then we have restored them with composites. Another case, management of a broken instrument. So, how many instruments are broken in this? Anybody has broken an instrument here? Broke? So now I'm not alone in the whole hall. Anybody on this side? Super. So keep breaking it, but make sure that you know how to manage it, right? That's very important. So in this case, again, this is what I learned in last 18 years of my practice, that 99% when the instrument breaks, it breaks about 12 to 14 mm from the cusp tip to the down. After seeing so many RVGs, we realized that this is the reason why it fractures there, because the curvature of the root canal starts from there, right? So in such cases, if you see, first what is more important is to create a straight line access to that instrument so that we can retrieve it, and that's what we have done. Again, with the straight line access, Teflon tapes in the other canal, we troughed it, we retrieved that instrument. Now, already we have troughed that tooth, so why we need to prepare it more, right? We have already troughed with ultrasonic unit, and that's what we did. We removed that instrument, and then I have just prepared the mesial canal to 2504 and the distal one to 2506 with activation and irrigation. There you can see that. And then finally, we have obturated these canals with the help of, again, bioceramic sealers. And this is the same study which is being published. I am happy to have this study published with Rajiv sir. It is already published in one of the international journals now that we have published it together. This is another case. Pulp stones, again, mid-distal, many variations in the root canal is being seen. Lot of use of ultrasonics I use in my practice before we enter into those root canals because they are very complex procedures. So you need to make them simpler before, once you enter inside that. So again, removal of those pulp stones, troughing, there you can see that. So different types of ultrasonic tips which comes, you can use them. If you see, these are the tapered ones to refine the walls, and then you have a round ones to smoothen the floor. Right? So any variations which are there on the floor, calcifications, you can smoothen them out with the different ultrasonic tips. And then you located the canal, followed by the orifice shaping with the Zizai orifice shaper once the canals are located. And then the roll of Zizai glider, one file to create a glide path. All canals, all 5 canals are being prepared to 1304. There you can see that, mid-distal. And then followed by Zizai. Just one file, 2504. And my preparation ends here. Now one thing which I want you to see here, if I would have been using any other file system, which is very aggressive, then what would have happened? It would have actually destroyed a lot of dentine of the tooth structure. And please mark my words, if you have to restore the tooth for a long period of time, you need to have a good dentine support at the coronal aspect, but also at the radicular aspect. If you make your canals too wide, you are just, it is good to look on a radiograph, but you are actually weakening the tooth structure, right? So that's what we did. We prepared the canals to 2504 and all the canals, and then I placed my Gacha Pacha. Now what you can see here, this is the tip of the Gata Parcha which has a confluence with the buccal canal. So just imagine a molar distal canal right here. Okay? Now the advantage of this system is what? Because it is not aggressive, it has maintained the dentine interdentally between the canals very well. And this is at the highest magnification of a microscope which you shoot right inside those root canals to see that. Right? So once that is being done, so it helps you to believe in a system that it is more conservative, more safer and more efficient to work on. And then we place the rest of the master cones. And finally, the army of the bioceramics move in. We flow the bioceramic sealers and we obturate these canals 3-dimensionally. So if you see the canal anatomy with Zizai is well maintained. It's a well-maintained canal anatomy. There is no unnecessarily extra preparation of the root canal dentine. Okay, but make sure that the irrigation protocols is very important. You have to follow it in between after every file. That is very important. So at a different angulation that you can see that. Another case, lower premolar. Lower premolar with 3 roots. If you see here, this is the lower second premolar with 3 roots, and this is the lower first premolar with 2 roots. All these variations you get to see. So we treated first the lower premolar with 3 roots. Again, use of ultrasonics. Big periapical lesion was there. A lot of ultrasonics we use so that we can refine the cavity. Again, thanks to world of magnification that helps you to see in those areas. It gives you a good depth of field. That means you can see deeper into those root canals. And there you can see that canals were located and you can appreciate the 3 canal orifices somewhere at the middle third or below the middle third into the root. Otherwise, how will you locate these canals, right? So they are very narrow also. So if I use any other system in such kind of cases, what will lead to? Lead to fracture of dentine everywhere. So what good I will going to do, right? So there you can see. And then once the glide path has been done, we use our rotary glider first after the hand glide path, that is 1304. And then we have prepared these canals to 2504 Zizai, 2 files, and we are done. Okay? And then there you can see under the microscope, from the lowest to the highest magnification, you can actually see the canals like a valley. It's not like a small dot that you are trying to figure it out. It's like a valley. You know what you are doing. And that's the beauty of magnification, followed by the placement of the bioceramic sealers. Again, what I want you to focus here is 2504 is the preparation which is minimally invasive with this. And you are able to maintain the root canal dentine throughout at the different levels that you can see. Right? So again, that is the role of Zizai, which actually helps you to work much more efficiently in all types of canals what you think about. You think about a canal, Zizai is the solution. That's what I can say. Another case. How many of you have done a perforation? Anybody with me? Sir. See. So, now if you do a perforation, and that too on a floor, and that too when you are trying to locate a lingual canal, buccal is easy, but lingual you do a perforation. I'll show you a clinical case. Again, if you see this case reported to me, we opened it up, and what you can see, a colleague of mine was trying to locate a lingual canal, but unfortunately he located a perforation. Okay, now, you know about the danger zone in a root canal, right? The inner wall of the root canal is a danger zone than the outer wall. Try to understand that the perforation is going along with the inner wall of the lingual canal. So, if you use any rotary system which is aggressive, what it will do? It will fracture the dentine like anything, right? So what we did, first what you need to do is to locate a canal before you seal the perforation, because otherwise every time you will keep putting your file into the same perforation. This happens. And that's what we did. We isolated the tooth nicely under the rubber dam. That's very important. And then what you see here is a gelatin sponge. It's a gel sponge which you use for like sugar cubes, some kinds, which you place in the extraction socket to control the bleeding. That's what we used. So that I can differentiate between what? Between a perforation and where I have to locate a canal, number one. Number two, because it has a hemostasis, so it forms a clot there. So it gives me a clean field to work onto the lingual side. Otherwise, every time I'm putting the file into the perforation. So that's what we did. And then we located the canal with the help of our hand files. And now once I located, I removed that Teflon tape from there. And now you can see very well my canal orifice is located. Now it is in the danger zone, as you can see here. So once you are in the danger zone, you need to be very sure how you can do that. So I placed, because I have to do my rotary again, so I again packed up another Teflon on the top of it, the gelatin sponge, so that I can differentiate which angulation I have to introduce. And that's what we did. I placed it, and then I used my Zizai. 2504, done, on the lingual canal. Now, the beauty of this system is, as this has a radial land, so there are less stresses onto the dentine. It has a passive cutting. So it preserves the root canal dentine into the danger zone. So eventually it preserves my strength of the tooth. That is what we look at. And that's what we did. Maybe that because of the screen that you can't see. And then once that is been done, I have obturated the canals with the help of the bioceramic sealers. And once you obturate the canal, then you follow the process of sealing the perforation with the MTA. That is very important. And there you can see that use of, after the obturation, we have used the MTA, same visit. This is with the MAP system which comes into the market from a company named PD. It's one of the beautiful systems to use to place MTA right at the site of perforation. And that's what we did. And then you condense that MTA with the help of GP points. Don't use metal pluggers here, because if you push with the metal pluggers, you will push the MTA into the interdental area. And that's what is being done. And then finally we have restored this tooth. Now this is another case. Last but not the least, for sure, management of the blunderbuss canals with Zizai and bioceramic. Especially if I have a pedodontist here, If I have those periodontists, yesterday I didn't share this case, I wanted to share it today. So this case, another 9-year-old female was there. She came to us, to the department there in the college. And then you see how thin the canals are, right? In such kind of cases, what you need to do is you need to create a good apical barrier with the MTA. That's what we did, right? First thing is that you create a barrier, placement of the MTA into the periapical area so that you form a 5 mm of a barrier. And then because we want to keep it in a less minimally invasive, we want to keep it minimally invasive, 2504 is the last file because it is passive file. We prepared these canals, same visit, because the beauty of this MTA, the setting time is 17 minutes. So I can just go, because earlier MTAs what we were getting, the setting time was 4 hours. So you have to postpone a case the next day. But today's dentistry is, once you have opened up a case, try to finish it on the same day. Follow the protocol. And that's what we did. So this is how exactly we do it. Open apex, MTA there, followed by, this is pre-op, MTA plug, post-obturation, and this is 1 year follow-up. You see a good apical barrier which has been formed, right? And I'm happy to share that this study of ours is accepted in the International Journal of Clinical Pediatric Dentistry this year for the publication. So again, those who are periodontists, you can believe in it. So we did the case with Zizai and bioceramics. So it is very well accepted. We got this acceptance, so it will be out into the publication probably in next 6 months with you. So you can study this case very well. So, and at the end, these are some clinical tips, how you can use a Zizai in your clinical practice. There are 9 points that you have to keep in mind to make it more productive and useful. So it is simple, smooth, and definitely it respects the anatomy, because these are the 3 things what we look in any file system when we start, even as a beginner or we are a seasoned practitioners. So it depends on you, that you need to believe into a system to work on. So are different ways that you know, so they are step by step, point by point, that how you can use this design. So you create a patency, shaping files, glide path, 1304, I've already told you. Follow the manufacturer instructions, that is very important. You need to have a checklist so that you know all steps you have done properly. That is very important. And definitely you have to operate at a speed which is recommended by the manufacturer. Okay, so you can go slow, but you can end fast. But you will not bang it, don't worry. You will not going to get a fracture, for sure. The beauty of this system is, yesterday those who are there in the hands-on, they tried with their hand, and we gave that system into their hand and we told them to break it. Do whatever you like. So I think you know better who are there in the hands-on pre-conference workshop. So these are the different things that you need to, points that you have to keep it in your mind when you're working with the system, so that you can make this system more effective for yourself, more predictable for yourself, and the utmost importance is you should make it more safer, because eventually when the file fractures, it's a nightmare. And once it fractures forever, right? So you need to take care of all these points, and you should know when to replace your rotary file. That is very important. Okay, so these are the certain things that you have to keep in mind. And these are the things, but before I end, I again, as a part of the co-chairman of the scientific committee of the Digital Dentistry Conference, already sir has told us. So I am honored to be with sir as one of the co-chairmen for the scientific this thing. So we welcome you all. Definitely we look forward for the young brigades to be there with us in Mumbai. Okay, so block your dates. Your vacation starts on 9, 10th and 11th June. I think that's the best thing. Digital vacation starts from 9, 10th and 11th June. Today we'll get the circular pass from sir to go to Mumbai. Okay, so this is the arena of speakers, the international speakers which will be there to grace this digital dentistry conference. I think something which we look forward as a future. Because as the world is changing and you are the young minds, you are the boss eventually, right? So we welcome you all to join there. And this is where exactly it is happening, at the Geo World Trade Center, one of the fantastic places to actually conduct any conference. We already had the opportunity to attend one FAMDent there. So it was like one of the different experience to do it. So state-of-an-art facility. with many things in there. So we welcome you all to be the part of this great mega event and help us to grow together, right? So we have scientific keynote sessions there happening, panel discussions, lots of hands-on workshop. You are most welcome to present your papers and posters there. That is what we look at. And we try to come up with something innovative ideas in digital dentistry. That will be grateful, and we will be looking forward to welcome you all on 9th, 10th, and 11th June, because 9th you should land there in Mumbai. So that 10th morning you are at the Congress, right? So we look forward to welcome you all. And again, I'm happy to share that this is our center in Delhi, which is a Zeiss authorized training center with Carl Zeiss, Germany. Lot of programs we keep doing. This is our one center. We do a lot of group programs supported by many of our colleagues from Money and other companies. And this is my own center where we do one-on-one endodontic courses. So I am actually blessed to have some of the senior endodontists coming to our centers for the program and helping us to learn and share it together. Right? So I welcome you all. And this is, as we are all active on the social media, that's a part of life. So you can join me anywhere, Facebook, Instagram, LinkedIn. That's how exactly you're most welcome to do. And this is the last slide, which is very important. Very important out of the whole thing. If you have to practice good endodontics, keep calm. Whatever happens. Because if you are not calm, you will do all the mishaps. Because endodontics is it's a procedure that you need to think before you execute. So that's what, start playing chess. I told my yesterday PCC students who were there, any of you play chess here? So those who don't play, start playing it. It will keep your mind calm because you will think before you execute. And that's what is required in the endodontic procedure. Thank you, one and all, for your patience.
There is one announcement that we have a complimentary coupon for faculty, for UG student as well as for PG students, and you have to go and take that coupon in front of swimming pool area. There are a lot of stalls have been put at the swimming pool area. You can enjoy all golgappas and tikkis over there. So that is free of cost from Convener-in-Chief of Dentocon 3. Thank you, sir. It was really great presentation. Sorry, I interrupt you.
Thank you, Dr. Prashant, sir. It was a wonderful presentation. Being an oral surgeon, I always scared with endodontics, but your presentation was fantastic. And listening Rumpa ma'am and your lecture, I came to one thing that if you want to earn money, start using money, either in the form of file or in the form of composite, sir. So thank you so much. It's wonderful. Any query, any questions for Dr. Prashant? I think there's no doubt, actually. It was wonderful. Thank you, sir.
Thank you. I would request both the chairpersons to please felicitate Dr. Prashant Bhasin. I would also like to request, Sir, Director Principal, Sir, to please felicitate the chairpersons.
Thank you, sir. We acknowledge presence of Dr. Rohit Shaukin, and I would request Dr. Rohit Shaukin, please come on the dais. I would request Dr. Himanshu Eran, sir.
Everybody, please, audience, kindly proceed for the lunch.